He's a fellow of the American College of Physicians and is a graduate of the National Security and War Studies from the National Defense University of Islamabad. He has been visiting professor at Cedars-Sinai Medical Center, Los Angeles, USA, as well as he's member of the Pakistan Medical and Dental Council. Presently, he is member of Senate of Comsat University, Shafai Tamir Millat University, Rawalpindi Medical University, and he's on the member of the Board of Governors of the prestigious Cadet College, Hassan Abdal. He was also Surgeon General and Director General Medical Services of the Pakistan Armed Forces. Besides that, he's editor-in-chief of Pakistan Armed Forces Medical Journal and chief editor of Life and Science, the Journal of NUMS. He's member editorial board and peer reviewer of many national and international journals and is author of over 70 publications. It's a privilege to have General Imran to chair this session. With him, we have our panel, and I'll quickly go through the panel. Dr. Muhammad Asad Salim, Chief of Cardiology at Shifa International Hospital and electrophysiologist, will be joining this panel. And we have Dr. Ghazala Irfan. She is Assistant Professor and Consultant Cardiac Electrophysiologist at the National Institute of Cardiovascular Diseases, Karachi. And Dr. Yavar Saeed, our own Assistant Professor of Medicine at AKU, will be a part of this panel. And further, I think Dr. Azam Shafquat probably would be joining us, but he is also one of the pioneers of cardiac electrophysiology in Pakistan, and he's professor at the National Institute of Cardiovascular Diseases, Karachi. So without any further delay, I would give the podium to Dr. Yavar Saeed to introduce our first speaker.
Thank you, Amir. We have an excellent session. And the first speaker of this session is my privilege to introduce Dr. Rehan Karim. Rehan Karim, as we all know, has been a very active contributor to Pakistan Heart Rhythm Society. He is a graduate of Aga Khan Medical College, class of 1999. He has done residency in internal medicine from Indiana University and followed by cardiology and EP fellowship at Louisville and Oklahoma universities, respectively. Rehan has published multiple manuscripts in peer-reviewed index journals. He served in the audit committee of Pakistan Heart Rhythm Society. He's currently working as the director of electrophysiology program laboratory at Hennepin County Medical Center and has an academic appointment as an assistant professor of medicine at University of Minnesota. So Rehan, thank you for joining us. And without further ado, please go ahead. Rehan, we cannot.
Can you hear me?
Yes. Yeah, we can hear you now.
We can hear
you. Perfect. And you can see the slides?
Yes, we can see the slides.
Okay, perfect. Thank you very much. Thank you, Yavar, for the kind introduction. Thank you, Dr. Imran, and thank you for the rest of the team for inviting me. It is truly an honor and a privilege to be speaking at this this meeting. So I'll be talking about a very important topic in electrophysiology, lead extraction, and why it is such a necessary program. So I don't have any disclosures as such. We all know that cardiac implantable electronic devices, or SEEDs, pacemakers, the defibrillators, and CRT devices have had a huge impact on patient care overall. And I think someone might need to be muted. So over the period of time, the indications for these cardiac implantable devices, they have really evolved quite a bit. Not so much for pacemakers. Pacemakers primarily accept some changes over the last some years. For the most part, the indications have revolved around symptomatic bradycardia, like sinus node or AV block, just in a nutshell. But over a period of time, the implantable cardioverter defibrillators and the cardiac resynchronization therapy devices their indications have evolved quite a bit, starting out from secondary prevention ICDs. Back in 1990s, there were several trials which proved which proved the benefit of the secondary prevention used for ICDs. AVID trial, we all remember, number needed to treat was in the order of around 8 over 3 years. Huge benefit. And after that, a lot of people started getting defibrillator. And then more data came, and the indications then expanded to primary prevention ICD implants with MEDIT, MEDIT2, and finally SCEDHEFT in early to mid 2000s. Essentially broadened the indications that pretty much anyone with persistently low EF of less than 35% ended up receiving these ICDs. And then for CRTs, again, multiple trials, and I'm not going to go into those details, but Companion, CARE HF essentially looked at really hard endpoints like mortality and showed benefit. So because of this, over a period of time, there has been a growing number of implantable electronic device systems. And according to industry estimates, over 7 million cardiac devices are in use worldwide. And annually, around 1.5 million devices worldwide are implanted. And because many of these patients, they have more than one leads, there are over 14 million leads worldwide, and over 2.5 million leads, new leads implanted annually. And this is not only the industry estimate. If you look at some data, so this is from South Korea, and not only the total number of devices have gone up, but because of these indications, if you look at per capita population, the implant rate has also gone up. And if you look at data from the US, here again, over a period of time, the number of devices have gone up. But if you note the proportion of ICDs as total number of devices, that has also gone up. So more people are getting devices, and more of those devices are these complex devices. 35% of new implants are ICDs and CRTs. The problem with that is that the leads, they are larger leads, thicker leads. They also have this shocking coil, and these coils promote more fibrosis. They have complex designs, so multiple cables need to go through the and surrounded by insulation, so more chances of failure of these devices. And as I mentioned earlier, CRTDs, they have more leads per device. So not only these devices have changed over time, but the patient population has also changed. So ICDs are, a lot of younger patients are getting ICDs, and they are living longer. So when they live longer, they need more battery changes. They have higher lead burden, and over a period of time, there is a higher risk of infection. So you can imagine more devices, complex devices, patients living longer. So there is increasing need to manage these ICD leads, especially over a period of time. You can see the annual rate of these defibrillator lead failures over a period of time. This is on the x-axis is the number of years after implantation. So for example, 8 years after implant, the older lead would have a higher risk of failure. So if you look at the data for lead extractions in 1990s, when we were not putting as many defibrillators, not many ICD leads were extracted. But then in 2009, this is from Lexicon study, almost 30% of the extracted leads were actually defibrillator leads. And then this is an industry estimate, data from case logs from Spectranetics, and almost 2/3 of the devices they implanted in this time frame were the defibrillator leads. And it's not just you pull these leads out and they come out. It's not like that, because these leads tend to fibrose. There is scarring in the vasculature, and many of the times you end up needing a laser sheath to cut off those adhesions, and because they are so much fibrosed into this thing. So these leads, those of us who are implanters, they have a hollow area where we put the stylet in, and around that, the coil is wrapped around. So if you think about it, the tensile strength of these leads is very low. So you pull them out and it just rips out, it can rip out that coil. So looking at the extraction of these leads, the indications, the main thing is infection. I won't have time to go over each and every indication, but I'll spend a couple minutes on infections later. But essentially, in a broad perspective, infection, venous stenosis, thrombosis, over a period of time, patients may have non-functional leads, redundant leads, need for any vascular access issues, chronic pain. Sometimes these patients have chronic pain due to these leads, and they need to be extracted. And more recently, if someone needs access to MRI and there is no other option, then patients may end up needing extraction of these leads. So as I mentioned, I'll spend a couple minutes on these on device infection, because this is a big chunk. If the system is not removed, the relapse rate is in the order of 50 to 100% of cases. Compared to if you remove the system, then it's less than 4% relapse rate for infection. And this is what we've learned from the med school also, that you have to remove the source of infection. And there has been a lot of data published, and it's not only relapse of infection, but also mortality. So this study is from Rochester, Minnesota, and antibiotics without removal of the device was actually associated with 7-fold increase in 1 month mortality. 7-fold increase in 1 month mortality. So it's extremely important to keep that in mind. This is an example of one of my patients who had venous stenosis, just with a single lead. So you don't need multiple leads to have this thing. It's just some people tend to, even a single lead could cause this thing. Now, you could ask a question, why not just cap these leads? And like here, and put a new system on the other side. Well, if you cap the lead, so even if it is not infected, let's say you upgrade the device, or there's a lead fracture and there is no more room in this lead, and you just put a new system on the other side, there is higher likelihood of infection if you have multiple capped leads. And abandoned infected leads, they are even difficult to extract, and they have worse outcomes. So these leads, if they get infected, they have worse outcomes later on. Risk of failed removal doubles every 3 years. So 5 years, 6 years, 10 years down the road, they would be difficult to extract. And again, even if a new system is MRI conditional, if they have abandoned leads, the tips heat up, and the MRI is contraindicated in those scenarios. Risk of erosion is there from the bulk. So these can be bulky and they can erode through the skin. And risk of infection increases 2 to 7% at each changeout as they need more generator changeout procedures. Again, risk of occlusion, central venous stenosis, SVC syndrome. And then if you imagine these number of leads, if they are crossing the tricuspid valve, they could result in tricuspid regurg and, cause even atrial fibrillation and right-sided heart failure issues. And this sometimes is ignored, but lead-on-lead interaction could even result in oversensing. I have seen that, and cause inappropriate shock and oversensing. So there's a very nice document from Heart Rhythm Society, which has a lot of details about transvenous lead extraction. But in this short talk, I would primarily want to emphasize one of the points, that it is a team approach. It is a team approach. In addition to a primary operator, you need a CV surgeon on site and immediately available, in addition to anesthesia, scrub assistant, fluoroscopy. In fact, many of the places here, they actually do these procedures, in a hybrid OR, that if someone needs thoracotomy, a perfusionist and CV surgeon is immediately available, because complications do occur, although they are rare, but complications like death, and especially vascular laceration, the tear near the SVC, if that happens, the patient can exsanguinate, and you may not have enough time. You may not have enough time to even open the chest. But these complication rates, they are serious, of course, but they are rare and comparative to complications with the other invasive cardiac procedures that we do, like AFib ablations or PCIs. And as the time has passed, these complicated people have gained more experience, and the rate of complications has come down. One, because of experience. Two, because of tools that we have available now. So, for example, one of the dreaded complications, as I mentioned, is SVC tear, and patients can exsanguinate. And then these type of devices, like balloon occlusion, bridge balloon, occlusion devices, they can give you valuable time that you can tamponade that tear while surgeon is opening up the chest. And this is also one of my patients. He had a huge, vegetation on the lead, as you can see. And this patient actually ended up having this huge vegetation embolize to pulmonary artery, and he went into PEA, and the CV surgeon had to, do an emergent thoracotomy. He did fine. He's doing okay, but it is extremely important from a programmatic standpoint, when the program is developed, to have all those pieces in place, and complication prevention and management is an extremely important thing to consider. And CV surgical team, they are an integral part of that plan, and the surgeon must be well versed with the procedure and understand what exactly he or she would be dealing with, and they must have an active role in this. So to summarize, as we saw, the number of implantable devices, they have increased, and as their indications have broadened. Many patients, they require multiple leads, and more leads make it more complicated, complex patient population, complex lead design, and long-term lead-related complications like infection, vascular access issues. They require a lead and system removal, and access to a comprehensive lead extraction program. It is very necessary for the long-term management of these patients who have implantable cardiac devices. So I will conclude here in the interest of time. And if anyone has any questions, maybe they can be tackled at the end, or whatever we feel is more appropriate.
Thank you so much, Rehan. Excellent talk. I think we can take one or two questions. So I'll just ask you first. In terms of lead extraction program, obviously, I think I have seen laser lead extraction, as you have mentioned as well. There is also obviously the system, which is not use the laser lead extraction program, like the use of sheaths, which are obviously. So what is your experience in terms of comparing these two, and which one obviously you think will be better in a resource limited country like us at the moment, in which the lead extraction program are obviously necessary requirement?
Yes, that's a great question. So, as I mentioned, as the time passes by, the chances of fibrosis and lead getting engraved into the vasculature wall goes up. And there are times when you may be able to take it out with the other sheets, as you mentioned. But I think it is important to, if you're thinking of having a comprehensive program, to have the laser system available at hand, so that you don't risk into doing partial extractions and more need for surgery in those places. So I think it is important to plan it in a comprehensive manner.
I have one more question, Rehan. So it is so in patients requiring mandatory pacing, how do you manage them in your center after lead extraction due to infection while waiting for a new device, and what are the outcomes? So that's one of the questions.
Yes, that is a great question. So many of the places, what they do is, someone is pacer dependent. We put a temporary permanent pacer on the other side. So essentially, like a permanent pacer lead on through IJ, or through maybe on the same side with a separate access, or on a different site with externalized old can, and until the blood cultures are negative, and then or when the infectious disease things that depending on what kind of bug is growing, Staph, for example, is notorious. So depending on that, we just use that temporary permanent device. Some places have used Micra and send them home temporarily, but so we do Micra, but we haven't, because it's very expensive to only use Micra for a month or 6 weeks, or whatever time frame is, 2 weeks. So from that perspective, I would of course not encourage that, but temporary permanent devices with an old can is a reasonable option.
Yabar, if I may ask a question?
Yeah, absolutely. Go ahead.
Yeah, so great talk, Rehan. We are a young nation of implanters, let's say. We are using less number of devices. Even I think all of our EP labs put together do not put as many devices as probably one high volume center in the US or in Canada would be doing. Now, developing, so we need an operator curve also, and people who are extracting need to be doing that. So being 5-6 centers over here, what would be your suggestion? Should it be a government-based setup which absorbs the cost and directs all our lead extractions to that center, or each center should invest in one? What would you say?
Yeah, that's a great question. And what I can tell you, again, a lot of these things can be political, but from a numbers standpoint, it is extremely important. So the HRS guidelines, from a training standpoint, they suggest doing 40 devices, and then to do at least 20 of such high-risk device extractions per year. So I think having one consolidated, and plus from a training perspective, from volume standpoint, it's important to have a high volume operator also. So it would always be, I think, a good idea for this type of scenario to have one go-to center and develop in collaboration rather than having multiple sites. I would agree with that.
Thank you.
Thank you.
Thank you, Rehan. Excellent presentation. Now we will move over to our next speaker, and I've asked Dr. Intisar to please introduce our next speaker.
Dr. Salik is going to introduce next speaker, sir.
Thank you, Dr. Rehan. Thank you, Dr. Rehan and Dr. Yavar, and it was a wonderful talk. And we will proceed with our next speaker. And our next speaker is Dr. Mohammed Talha Bin Nazir. And so he is a graduate of Rawalpindi Medical College from Pakistan. He also obtained his MRCP from the Royal College of Physicians, London. He has an FCPS in cardiology, and he's from College of Physicians and Surgeons of Pakistan. He did his fellowship of cardiac electrophysiology from Queen Elizabeth Hospital, Birmingham. Moreover, he's also a fellow of, he also obtains a fellowship of Royal College of Physicians from Glasgow and Edinburgh, UK. And moreover, he also has International Board of Heart Rhythm Examiner certification. His areas of interest include electrophysiological studies and ablation, his bundle pacing, and percutaneous coronary intervention as well, percutaneous transcatheter mitral commissurotomy, cardiac CT scans, and cardiac gated SPECT. And currently, he is working as an assistant professor of cardiac electrophysiology and head of cardiac electrophysiology department at the Rawalpindi Institute of Cardiology. And he's also general secretary for Pakistan Heart Rhythm Society. And today he will be talking about atrial fibrillation as an experience from Pakistan. So over to you, Dr. Talha.
So I hope everyone can hear me. So I'm just going to get my presentation should be up. All right. Thank you very much. I hope the presentation is visible to everyone. And
we can hear you.
Yep,
yes,
that's great.
We can see the presentation. Yes.
Brilliant. Okay, so in a sense, I'm going to be talking about the experience that we've been having in Pakistan, although it's, I think, still too early. But nevertheless, we have taken a start. Not only myself, I'm sure some other centers as well in Pakistan are actually performing ablations on and off. And unfortunately, we are set back by the global pandemic as things are. So really, I don't have any disclosure to make. I'm just going to start off with a case as it is, which we had. So it was a 30-year-old gentleman that is working as a laborer. He was a resident in the local society. He presented to the ER in our hospital in 2018 with palpitations, chest pain, and dyspnea. He didn't have any significant history. Otherwise, the duration of all of these symptoms had been almost 8 to 9 hours. He had been having small bouts previously, but he had ignored them. But now he had felt a bit dizzy and dyspneic as well. So he was very much concerned that he wanted to get a checkup. When he landed with us in the hospital, he had this ECG. The ECG by our team, where we had in-house consultants as well, was of course diagnosed as an atrial tachyarrhythmia, irregular, and was diagnosed as atrial fibrillation. And definitely the historian was good, so he said that the palpitation had been there for about 8 hours, along with the symptomatology he had been having. After discussing, cardioversion with him, he opted for chemical cardioversion. He was given amiodarone, where the rate was eventually controlled and eventually the rhythm as well. After stabilization, because he did not have any other risk factors, he was discharged on simple potential rate control therapy, where if in the future he has some arrhythmias, they might be the symptoms might be less severe. Unfortunately, the following year, he had almost 4 presentations in the ER with similar complaints, which were treated similarly. And during this period, over this period of about 7-8 months, his hematology, biochemistry, his echocardiography, and interestingly, his angiography, everything turned out to be normal. However, on 15 September 2019, he was referred to our department, where my colleague and myself, we assessed him. As per se, we had the discussion with him, and because his symptoms were lasting for every episode, and one, they were frequent, he was having enough symptoms to warrant him to present to the hospital. He opted for some pill-in-the-pocket regime. We managed to get some flecainide arranged for him, although it is very difficult to do that. I'm sure everyone acknowledges in Pakistan. He's remained on flecainide as a pill in the pocket, but yet he had 2 or 3 episodes. And he said, well, by the time I take my flecainide, Unfortunately, it's still, I'm sometimes at work, and because, you know, the kind of work he was involved in, he felt very symptomatic. He was getting frowned upon by his supervisor. So he said, well, I'm not satisfied. We talked to him, and then we put him onto flecainide on a very small dose for a 6-month period. Unfortunately, despite that, he had still breakthroughs, and he had to finally come to hospital. And then we had decided, well, we talked to him, should you opt for something else beyond medical therapy? So he, luckily, we had been blessed with having some equipment available, which I'm grateful to our institute as well, which meant we had the cryo system and we had the 3D mapping systems available in our center. So he opted for catheter ablation, and we discussed the risks and benefits of all of this. And this was one of our first cases that we actually managed to proceed upon. So when it came to catheter ablation, the way we take it for the 15 cases that we have done so far since October the 1st, we had to discontinue flecainide. Otherwise, I would have probably continued it. But because the flecainide is quite difficult to get hold of in Pakistan, especially more so even in these in this COVID pandemic, we just decided that we needed to discontinue flecainide. We started him on rivaroxaban. I just felt that I would be a bit more comfortable when it would be coming to opting for ablation. And the ablation strategy that we opted for was a cryo ablation. And since it was a paroxysmal, true paroxysmal atrial fibrillation that we got to feel it was, we opted for a pulmonary vein isolation, solely that. However, we had another echocardiogram because we were just concerned if there was any thrombus formation, which there wasn't. And we could not see any other structural abnormalities with the heart. The left atrial size of this gentleman was 39 millimeters on the M mode. We did not do any volume indexing, but we just went with the same old style M mode measurements. So on the day of the procedure, we asked him to come in the morning. After taking informed consent, we kept him on uninterrupted anticoagulation, which means he was taking rivaroxaban in the afternoon. So he did not take it on the morning. However, he was going to be taking it on the very same day after the procedure, had it gone uncomplicated. He received local anesthesia, conscious IV sedation. He had two, femoral vein sheaths, one of a 7 French and one of an 8 French. We opted to proceed towards passing in a decapolar CS catheter. In the initials, because it was our first case, we just thought we wanted to be as simple as possible. So we took in a steerable one with a 252 spacing. We exchanged the 8FR sheath with the transeptal SL1 St. Jude transeptal sheath with a BR key needle, and the way we did the transeptal was a fluoro-guided puncture with a pressure transducer, which I'll come to very shortly. Once going on towards the left side, I tend to give the heparin around about just before the transeptal puncture. Of course, we have everything in standby. That means anything that might require, urgent, emergent pericardiocentesis, which means an echocardiogram, which means also surgical backup. We are lucky to have a suite, which is in a way shared by the cardiology and the cardiac surgery department, and also the necessary equipment required for pericardiocentesis. Once the transeptal was done, we exchanged the Medtronic flex cath over the wire in order to make ourselves and the balloon maneuverable in the left atrium. So this is just going through what we have done is sorry, I'm just going to take a laser pointer over here. This is the left atrial, iliac oblique projection, where we have the coronary sinus catheter, which is a decapolar steerable. This is the SL1 sheet, and I tend to bring it down in the left atrial, left anterior oblique projection. We're just doing the transeptal puncture. Once the transeptal puncture is done, what we do is we take the wire across in the PA projection or the LAO projection. And once it's there, I try and ensure actually that I place the wire in the left upper vein, because the next sheet that we are going to take through is a 13 French flex cath, and is quite a bulky one. Sometimes it does get stuck at the atrial septum and it can take a jump forward. So I just have the wire more in line, so it makes it a tad more easier for the flex cath to get into the left atrium. And here we can see it's a much more bulkier sheath. And this is the flex cath, which is just going into the, so I had done the puncture, I had taken out the transeptal sheath and now went over the wire with the flex cath. Once in the flex cath is there, what we just do is, oh, sorry if I can just probably, I'm not sure if this will, yeah, beg your pardon. So once going with the flex cath, what we do is we I try to engage the left upper pulmonary vein here. What we've done is we've taken the achieve catheter, which is within the lumen of the balloon. We inflated the balloon at the ostium, and of course, whilst going in, we looked at the pulmonary vein potentials, and I try to, if I can, keep the electrodes of the achieve catheter at the ostium in order to get the pulmonary vein potential, so I can see the time to isolation rather than doing a retrograde pacing from the vein into the atrium. So here we got very good occlusion. We did a freeze over here, and luckily in the first freeze, in the first case, alhamdulillah, we actually managed to isolate this left upper vein. From there, what we did was we moved into the left pulmonary vein, inferior one, and again, as you can see, what we did was we maneuvered into it. We've taken the achieve catheter in, we've occluded it with the balloon, and we did not get any leaks. Although I must say this was not the first fluoroscopy that we did, but we did get a leak superiorly and inferiorly. More commonly, it was a bit difficult, but when we got the hockey stick-like appearance in line, we could see a good occlusion. And again, we did a freeze, which was a 180-second freeze. And alhamdulillah, we also got this isolated in a very nice manner as well. Similarly, we did this, we do the right pulmonary veins as well. For the right upper pulmonary vein, and for doing the right-sided vein, as you can see, I've taken my coronary sinus catheter, taken it up into the subclavian vein, where I'm doing phrenic nerve stimulation as well, because this is something that we do. One, we stimulate, we visualize, and we feel the abdomen as well for the phrenic nerve movement. And at any time we feel it's diminishing, we just stop the freeze, because we did not want any phrenic nerve palsies, of course. So here again, what we did was in the right upper pulmonary vein, we got a good occlusion. We did a single freeze over here as well with the coronary sinus balloon, sorry, beg your pardon, the cryo balloon. And in the first freeze, we managed to get rid of the pulmonary vein potential. So we managed to isolate it as well, and we got exit block. A bit more difficult, the right inferior pulmonary vein. I fell through, actually back through the transeptal puncture, but luckily managed to fish my exchange wire through and took the flex cath through. Once maneuvered in, again, we had a very good occlusion of the right inferior pulmonary vein. Similarly, we were doing the right phrenic, the phrenic stimulation, and 180-second freeze, we managed to isolate the right inferior pulmonary vein as well. So this was our general strategy. This is a cryo console. It's by Medtronic that we have. It's the one right now that is present, and probably there are a few more coming in this year, or may have came out in Europe as well. But because of the pandemic, there have been delays. But the Medtronic one is quite nice, that we use the 28mm balloon over here rather than the 23mm one, and we got a very good temperature drops at the start, and once it's at -30, the balloon kind of sticks to the antrum of the veins, where then you can maneuver around with the controls on the flex cath to get a bit more contact on the antrum and get better isolation as well. So just a very quick electrogram where we have pulmonary vein potentials, and this is just a series where you can see just the pulmonary vein potential moving off, and in eventuality it had disappeared. Similarly, we had the pulmonary vein potentials when we were doing the left inferior pulmonary vein, and again we've got very nice potentials which suddenly disappear. This again was during the freeze I was talking about in the previous fluoroscopies. Right pulmonary veins, because we're doing the phrenic stimulation, we do have pulmonary vein potentials which eventually disappeared, and again the right-sided veins had gone off. Post-procedure, we tend to, of course, keep the patient in, and on the same day we have an echocardiogram, and I tend to go for a chest X-ray, although it's arguable. We did not have any complications on this first case, alhamdulillah. And since then, now this is a patient who had been coming in several times to the emergency. It has been, because we did this on the 1st of October, that I know the follow-up is very short. We've just crossed the blanking period, which is of the first initial 3 months, but yet this person is alive. That's the first thing. And of course, he's not had any further runs of atrial fibrillation. He's not had any symptoms. And interestingly, he's not on any antiarrhythmics. The only anticoagulant he received was 20 milligrams of rivaroxaban for the first 3 months. So what we did was, because the patients, they were very much concerned about their rhythms, we did say to them, we can have a monthly follow-up, but some of them they were keen, and this particular patient was keen. No, I would like to come after every 2 weeks, just make sure that, you know, you've done your job right. So we didn't have any problem with that. It was a patient choice. We did a halter at 2, 4, 8, and 12 weeks, and throughout the halter, it was a 24-hour one. He did not have any symptoms. He had a normal sinus rhythm throughout. And it's been, I guess, almost 4 months where he's not had any further arrhythmias. So this is the general procedure we followed for all 15 ablations that we have done at my institution. This is just the team where we are with our executive director then and there. However, I must give a lot of credit to my previous executive director, General Azarkiani, who made a lot of efforts to actually make this equipment available for us. But nevertheless, we were intending to start off in March, but I think the minute we just got the console, because the team was due to come from Turkey to set it up, unfortunately couldn't do, as we all know, because of the travel restrictions. But anyway, alhamdulillah, on 1st of October last year, we managed to do our first ablations and first set of ablations. Since then, we've done about 14 ablations, and they have been done quite well, alhamdulillah. And the best thing is they have been done free of cost. They have been done for the common man. It's not people who can afford it, it's people who need it. And there are plenty of them. However, there have to be strategies which we feel need to make it much more viable in the long run for this population of our country. Just a bit of data that we had gathered. The average age of the patients that we had was 51 years of age.
Sorry to interrupt. We are just running out of time.
Okay. I'll just quickly wind up this. So what we've done is we've done about 14 patients. Average time to cryoballoon ablation was about 2.1 years. We had pretty much quite a it's a very low CHA2DS2-VASc score that we've gone for. The average age, left atrium is 38 millimeters, and the ejection fraction is preserved. The anticoagulation, it's pretty much standard. We've not done anything unusual. The cryoballoon size that we've used in all 14 of them is 28. Procedure durations, they vary, but on average about 79. Time to isolation is about 29 seconds, and only one we've had as phrenic nerve palsy. That was, we could not complete the whole procedure in that lady. However, 1 week later, the phrenic nerve palsy actually reverted, and alhamdulillah, we didn't have any issues. We've not had any other significant major complications, minor ones such as vasovagal, pericarditic chest pains, which have been managed. This was one case where we had got a left common ostium where I managed to take the venogram. This was a difficult case, but luckily he's not, I had to do at least 3 cryo freezes in order to isolate that, but I'm still not sure if that will remain and stick. So all in all, I think it's a procedure that needs to be done. It's needed in this country. Many patients of atrial fibrillation are not managed up to the mark. The outcomes are too early, but seem to be fruitful. It does improve quality of life, and if done properly, it's quite safe. With this, I thank you very much for your patience.
Thank you, Dr. Talha. That was a very informative and very wonderful talk. So we don't have much time for questions. The only thing I would want to ask about this talk is that being in a private setup, how cost effective do you think that ablation can be, because we practice in private setup? So what?
So working in a private setup, I have tried tooth and nail, and I think currently the cost estimate that has came out to be for one cryoballoon ablation is at approximately around about 600 and 700,000. Having said this, the company, the principals, they have been talked to very, I've had several conversations with them, and we are trying our level best to bring it down for the country. And when it comes down, not for just one institution within the country, and that will be around about 400,000, which I expect they will agree upon, then naturally that can act as a precedent for other institutions, be it private, be it civil governmental institution, to put up a case and bring the prices down. So I believe for symptomatic patients, which are selected properly, because the patient selection is very important, because we have a big rheumatic group which we need to avoid and ablate, but at the same time work up our patients properly. So the true people, true paroxysmal atrial fibrillations, which there are many nowadays, and you see, I think they will benefit from this ablation. And if the prices can come down even further, that will be much cost effective as well.
Thank you, Dr. Talha. That was a very impressive talk. And now I would want Dr. Yawar to continue the session.
Thank you, Talha. Excellent talk. And yes, I think there is no two ways about the need of complex mapping and ablation in patients with complex arrhythmias. So that sets up for our next panel discussion, which is the role of 3D mapping in Pakistan. And my apologies to Dr. Azam Shafquat. I think the program that got out has got his name on it, but he obviously did not agree in the first place to present because of some commitments. I welcome all the panelists, Dr. Imran Majid, Dr. Ghazala Irfan, Dr. Asad Salim, also Dr. Rehan Karim, Dr. Ahmed Eldamaty, and Dr. John Sapp, if they can all contribute in this panel discussion on the role of 3D mapping in Pakistan. So I'll just start quickly, just to tell our audience that how many 3D mapping systems are there in Pakistan, and then obviously we will be open for discussion. So we'll start with Karachi. All three centers in Karachi have 3D mapping systems, include Khan University Hospital, Tabba Heart Institute, and National Institute of Cardiovascular Diseases. We all have NAVIX mapping. I think there is obviously a plan to get a carto mapping system in one of these centers. And the Forces Institute of Cardiology in Rawalpindi is obviously leading this in terms of 3D mapping systems. They have the carto mapping system, the NAVIX, and also the arrhythmia, and has been doing multiple cases at the moment. Lahore, I think Rawalpindi Institute of Cardiology, I think have just acquired the carto mapping system, Dr. Talha, and PIC also, the Pakistan Institute of Cardiology in Lahore, also have an NAVIX mapping system. And Dr. Zahid Islamawan in Hayatabad Medical Complex also have NAVIX and 3D carto mapping system. So my questions, obviously, to all the panelists, especially, that obviously it's a matter we are just behind the curve at the moment in terms of doing these 3D mapping cases across all centers in Pakistan very frequently. Our experience at AKU that we have done around 20 cases over the last 2 years. COVID pandemic obviously have stopped us from moving that further along. But obviously there is a lot of problems when you initially set up this system. And I'll start with Dr. Imran Majid about how he thinks about the role of these 3D mapping systems in Pakistan and how we can go about making our colleagues in general cardiology colleagues believe in the effectiveness of the system. So Dr.
Yeah, Yawar, thank you very much. Just a few comments. Obviously, cost efficacy is the big question. Let us not underestimate what electrophysiologists can achieve without a mapping system. Now, me coming from a generation which started its career when the mapping systems were not around, and even when we talk of atrial and ventricular tachycardias, so, one had been doing a lot of these atrial and ventricular tachycardias. If I recall correctly, even in the years when I was active, about half the volume of atrial and ventricular tachycardia ablations that one carried out was actually with the traditional system. The benefit of mapping system was obviously that we are able to reach the approximate area very quickly. And it saves a lot of, obviously, in terms of radiation, and not to forget the stress of the wearing the lead sheet and stress on spine and so forth, which are actually important issues to factor in. But the looming question in Pakistan has always been the cost that we pass on to the patient. And for all the years that I had been very active in ablations, it was actually the dominant question. Now, I know the situation as what is happening in Rawalpindi Institute of Cardiology. Talha is fortunate that for as long as the governmental system continues to support financially, or the situation at NICBD, I believe, is a similar situation, that the cost is not passed on to the patient. Otherwise, whenever we cross that 4 or 500,000 rupees mark, it becomes a challenge. Just one other remark, and that is in support of mapping systems. It's not only for the atrial fibrillation or atrial or ventricular tachycardias. I would propose there are actually other conventional situations also where one felt that a mapping system would come in very handy. Very peculiarly, although one had a sizable experience of ablating Mahaim fibers, and that was unbelievable that one had faced that situation in over 30 instances. I wish I had used a mapping system, because I'm not sure what experience that all are, you learn it colleagues have of mapping and ablating Mahaim fibers. It's very difficult to get it at the AV junction. I always found it much more convenient to go for the ventricular insertion of the Mahaim. So in that sense, it's like, treating ventricular tachycardia. And the problem with Mahaim is that it may not have just one single spot of insertion in the ventricles. It may actually bifurcate or trifurcate, or there is a sizable arborization, multi-branching, and you may have to do a number of spot touching before you get it. Therein, I believe the life would have been, if I recall my times while ablating, I believe my life would have been much simpler had I accessed or had used 3D mapping system. So these are all my comments. I believe the issue is cost. Now, I do not believe that industry would be able to help us for long, because once volumes build up, they have to look up at their global equation, and ultimately they will always be. They may be subsidizing us initially for a short while, but they'll be very quickly coming back to balance their own economic equation. Thank you.
Thank you so much, Dr. Imran. If I can take Dr. John Sapp opinion, obviously he's coming from a center which does such high volume work, and he's one of the pioneers in cardiac electrophysiology field. So I just wanted to get his opinion about how he, when he started, obviously in Canada, how he started with this complex 3D mapping system, obviously, which has developed over time. So if he can shed some light on it, we will be very grateful.
Thank you very much. Thanks for the opportunity to join you. We started with 3D mapping systems approximately 20 years ago, about 21 years ago. And it grew increasingly frequent that we would use it as the complexity of arrhythmia that we treat grew. But when I say complexity, I don't mean how complex the actual arrhythmia is. So for example, a Maheim fiber is quite a complex arrhythmia to sort out and to ablate. Atrial fibrillation is not that complex. What is complex is the anatomy. And that is the gift of the electroanatomic, the 3D mapping system, is to give you a three-dimensional image of where you are working, and to help our poor human brains combine the electrical information that we analyze as we see it point by point, but to assign it to the map so that you can remember it, see where it was, go back to it. That is the true enabling feature of electroanatomic mapping. So it's not smarter than we are, but it is it does allow us to remember where we were, how we got there, and to get back there. And to make it into a three-dimensional shape that no matter how good we are at analyzing fluoroscopy, the 3D system, it is easier. It's clearly easier. So they have a huge role. There are two costs. So I very cognizant that I speak from a Canadian perspective where we are very fortunate. That there's the cost of acquiring the system, and then there is the cost of the disposables of the catheters and so on. And the costs of the catheters have come down dramatically over the years. We now use most of us use electroanatomic mapping for all of our ablation cases, for AV node reentry, for pathways, for flutter, because the cost is almost the same as a non-nav catheter once you have the system. And it doesn't really make you better for many of those things, but it does make it easier, and it probably makes it a little bit faster. And it's addictive. Once you're using it, it's hard to put it back. Particularly some of these the newer innovations. So irrigated RF is clearly an advance. But the contact force sensing catheter, very difficult to show the advantages of those, but it's like, as one of my colleagues said, it's like crack cocaine. Once you start using it, you just don't want to go back. Anyway, I think perhaps I've said enough, unless there's any question for me.
So initially, Dr. Sapp, so obviously we are starting here in AKU, and finding it difficult is the training of the team. Obviously, our technicians, obviously we don't have industry reps here, which are coming often. Yes. And what we found difficult is obviously that in terms of setting up the machine and everything, they are okay. But in terms of going for difficult arrhythmia like re-entry tachycardia, so focal tachycardia, we obviously have done few, but in terms of re-entry arrhythmia, we have found that it's obviously typically it will flutter. Obviously, it is something that we can use our fluoroscopic knowledge to it. But VTs and re-entry arrhythmias in patients with congenital heart disease, it is coming as obviously a challenge to us. So what you can advise in terms of getting around this scenario, what your experience is in that respect?
That's a great topic of conversation. We live in a relatively remote part of Canada, far away from the center. And the industry, some of the companies do not invest in reps out here. So I do not have a representative from Biosense when we do a CARTO case. So we have always spent a lot of time training our nurses, which is a challenge because they turn over. but after many years of yelling at administration, we finally were able to achieve a dedicated group that aren't always being rotated through the cath lab. So we have a number of nurses who are in the EP lab. That's their job. There are other cath lab nurses who rotate through just because of human resource management. But we have some, and so then they can build up enough experience that we can teach them. They know how to measure a post-pacing interval. They know how to measure activation timing, with us on the and they run the electroanatomic mapping system for us. So, but that's been a huge investment, and it's a continuous investment in teaching our staff. But it's liberating not to be dependent upon industry for that.
Thank you, Dr. Sapp. If Dr. Eldamaty is here, obviously he's established in Cairo.
I think Ahmed Eldamaty's input will also be important because he went to a place very similar at the time that he probably landed. They may have had more resources, but I think he struggled also. So his input would also be very vital.
Yes, so if Dr. Eldamaty can give us his overview about what his experiences have been with regards to this 3D mapping system, please go ahead.
Sure. Thanks for the invitation to start with, to be with you here today. I hope you can hear me well. So we started off with the 3D mapping systems, I think 15 years ago now. I guess there are many factors that come into play here. So first, when we started off, I think physicians were eager to try the technology and to know how it works. So we used to do it for PVCs and for atrial tachycardias, even more than the indications that we are using nowadays. For the time being, when physicians are starting to be confident with it, I think we are restricting it to cases that obviously cannot be done without it because of cost limitations. So most of the centers now are restricting it to cases with atrial fibrillation, cases of ischemic ventricular tachycardias, and cases of complex atrial flutters. Perhaps 10 years down the road, when the cost is not a limitation anymore, and I guess this is quite a similar model to what's happening in Pakistan, we will be starting using it to most cases. And the most advantage that I see is targeting, near zero or zero fluoroscopy, because I think this would be a really important advantage. But for the time being, because of cost limitations, we are using it, only for the cases that cannot be done without it.
Thank you, Dr. Eldamaty. If Dr. Ghazala Irfan is here, obviously we would like to get her opinion about obviously the use of 3D mapping in NICVD, National Heart Institute of Cardiovascular Diseases in Karachi. And then if Dr. Talha can also chime in about his experience at RIC. So Dr. Ghazala is not here. Dr. Asad Salim, if you your views about it.
Yeah, but I had been, I work in a private setup, and I've been, for the last few years, we have been thinking of getting the 3D mapping system. So, I mean, it's a problem in Pakistan in the private setup. I mean, first they ask you to give you a feasibility about how many patients that you do, and I mean, would it be cost effective? I mean, for in a private institution as opposed to in a government institution. So the thing that I think what I've been thinking is that, I mean, the way to bring down the cost would be if you start using the system in in your every case, like for ABNRTs, for everything. I mean, if you focus, because then the volume will go up. So it's all across the country. I think if we start using it for every case, the volume will go up, and that will bring down the cost of the procedure. Uh, Another big thing, I mean, I think that Dr. Eldamaty also mentioned, I mean, fluoro, it will be a big advantage, the 3D mapping system, that we can avoid the, I mean, fluoroscopy. I mean, the radiation exposure will be is a big thing for us. And I mean, not wearing the lead, I mean, all of us, I mean, starting getting backaches and I mean, other problems. That's a big thing in 3D mapping system, which is a very big benefit. But I think if we start using for every case, that probably will be helpful for us.
Absolutely, and I think obviously if
That will
especially
also increase the experience. The staff will get more trained. Your own experience will get better. I think that's the only way I was thinking that we can move forward. Otherwise, it'll be very difficult here.
absolutely, it's not easy to obviously do these cases, 1 or 2 cases a month,
Yeah.
and then training the staff with it. It's probably we have to find a solution to it. And also obviously with pediatric cases are also on the rise. The use of 3D mapping probably, I think.
And moreover, another thing is that, I mean, in Pakistan, I mean, when the patient comes to us, I mean, he wants one procedure and that's it. He does not want a failure. I mean, that's a big problem. I mean, you even in atrial fibrillation ablation, in very good hands, the procedure success is 1.5 procedures per patient. So you tell the patient upfront, I mean, sometimes that you might come back to us for another arrhythmia like an atrial tachycardia and you have to go through the procedure again. That mentality is not here in Pakistan. They would come to you, they don't have the money, the resources, and then they would come to you. They want a single procedure and they want it to be successful. So that's a real problem here also. I mean, you cannot just keep on bringing the patients back. And so that'll be a big problem.
Absolutely,
There's
I
a
think
cost and everything.
and especially if the patient is paying out of his own pocket.
Pocket, yeah.
The big issue for us that and we may have to counsel the patient beforehand that he may require 2 procedures, but as we are saying, it's not easy.
That's not, I mean, it's a difficult thing in Pakistan.
Absolutely. Dr. Talha and Dr. Amir Hamid, also I would like to get their opinion about it. So Dr. Talha first, please.
Yeah, I think, thank you, Yaver. I think pretty much everything has been said more or less, but I think the first thing is the cost, because if you can get the equipment, get the disposables, then you can do something with it. And having the added advantage of a gadgetry in the armamentarium is always beneficial for complex arrhythmias, if it is, for example, VTs, complex atrial flutters, atrial fibrillations. Nevertheless, I think it's very beneficial to have it, but the question is, will someone be able to afford it? I mean, for instance, this is the exact question I have to ask myself 100 times. I do agree with Dr. Asad to some extent as well, that if the volumes go up, if it becomes a common thing, then possibly the prices in the long run will also come down. So having that, in addition to that, not only radiation, I think another thing which we overlook as cardiologists is, and which my teacher, Jan Imran, sitting there, he told me is take care of your back, take care of your cervical, and the leads that we wear. It's horrible for the number of years we wear them. And I think even right at this age, probably I'm having some backaches as well. So if we can get rid of all of these things and the ergonomics can improve, which I think the 3D can offer, but bringing the cost down and giving the better ergonomics, getting rid of radiation, it has benefits. But I think in Pakistan, it will take a bit of time. But I think if we start moving cautiously, we can get to some extent in the right direction.
I think Dr.
Thank
Amir.
you. Yeah. So I have heard everyone, and I got lovely thoughts. And John describes it very well. It is addictive. It is like you're driving a Beamer. It makes your life really good. Issue is the cost, and issue is the patient mentality. While I was training in Canada, and an American patient used to land, you walked into the ward, and the nurses, you could tell that there was an American patient around. So it's how you see. The Canadian patient is very, very good. And the Pakistani patient basically wants one procedure because he cannot pay for the other. So I think in the long run, cost effectiveness, we in the developing world need to have a dialogue with the companies that make these devices. Clearly, it has to be differential pricing. And if we can hit that, the Indians have done that. When Indians talk to these companies, they say, look, you're looking at a 1 billion population. So I would say that when we talk to these people, we should be telling them you're looking at 300 million people. And it's not a small market. And if you can bring the cost down, you will get the dividends. It's just that you need the right kind of policymakers to talk to the right kind of people. And they do understand. Pfizer, Global, everybody, they understood that when the Indians said that when you sell us Viagra, you have to give us a special price. And that is what we need, basically good policy making and government to kind of support these. Just as I said for the first session, for lead extraction programs, you need government sponsorship, because it's like initially it's like a dead well where you keep putting things in before you hit anything. Thank you.
Thank you, Dr. Amir. I think Dr. Ghazala Irfan have got some issues with the mic. She have had a comment that at NICVT, they are trying to use 3D as much as possible, so our experience increases. So if they are doing one complex case, they use the same patch for AVNRT and AVRT patients as well. So this is something that echo Asad comments as well, that the more you use it, the more easier it will be, and the technicians and whole team. So I just wrap up this session. It's an excellent discussion on the role of 3D mapping. And my obviously advice with regards to this is that take one step at a time and start with simple cases first. That's what our experience has been, that we have started with focal atrial tachycardias first, and we have done one atrial fibrillation ablation, and now obviously we are moving on to more complex re-entry arrhythmias. So I think, yes, it's the team building that is required, and obviously all these comments that talking with the industry, discussion with the stakeholders about reducing the cost down, it's important. So we are moving on to our next speaker, and we have an excellent world leader in terms of genetic arrhythmia. And he's somebody who has been contributing a lot with Pakistan Heart Rhythm Society, initially with Dr. Rehan Nazir, and now obviously every year we have seen him, Dr. Arshad Jahangir. So Dr. Arshad Jahangir is the medical director, Center for Advanced Atrial Fibrillation Therapies, and he is an associate director of Clinical Cardiac Electrophysiology Fellowship and adjunct clinical professor of medicine in University of Wisconsin School of Medicine and Public Health. So Dr. Arshad Jahangir is a world leader in genetic arrhythmia and inherited cardiac conditions. He's graduated from Dow Medical College and then completed his intern residency in internal medicine and fellowship in cardiology and cardiac EP and cardiac pharmacology at the Mayo Clinic in Rochester, Minnesota. He has served as a faculty and then as a professor of medicine in Mayo Clinic, and he's currently an adjunct clinical professor of medicine and University School of Medicine and Public Health. And he's also serving as an associate director for Clinical Cardiac Electrophysiology Fellowship Program. So I'll ask Dr. Arshad Jahangir to please present, and it's our pleasure to listen to him in our session in Pulse 2021. So Dr. Arshad Jahangir.
Can you see my screen?
Yes, we can.
Yeah. So good morning, and thank you so much for that kind introduction. Thanks for the organizers, Dr. Amir Hamid, Sayyid, Yawar Sayyid, and Dr. Usman Fahim, Dr. Zainab Samad, and Ms. Sana Makhani for the opportunity to present some of this topic, which is, I think, as important as the previous topics you have been discussing. The problem that I see is that there is a lot to cover in 30 minutes. So the whole spectrum of genetic arrhythmology, extending from sinus node dysfunction to AV conduction disease, atrial fibrillation, and supraventricular arrhythmias, VT, sudden death syndrome. So I think the focus have to keep the focus on primary electrical problems of the heart that increases the risk of sudden death. So, and I'll try to highlight the main syndromes, and then to answer questions, especially our approach towards patients and family members, how we analyze, risk stratify, and then manage these patients. So let me remove these. So as you know, I think that for this audience, especially sudden cardiac death is a major challenge that we are all facing, with 300 to 350,000 deaths we see in the United States. 1 every minute, and much larger than the combined death from all of these multiple conditions listed. This sadly, this slide was made several years ago, and it has not changed much, with the proportion of death which are sudden of cardiac deaths remaining similar to what we have 20 years ago. So 50% of cardiac deaths are still sudden cardiac death. So 1 of 7 deaths in the United States are a sudden cardiac death. And within that frame, I think the focus today will be in younger patients. In elderly patients, the cause of death is related to coronary artery disease and primary dilated cardiomyopathy or primary muscle disease like hypertrophic cardiomyopathy. In younger patients, we are talking more about primary electrical problems, which are the genetically determined type of arrhythmia, the way we approach it now. The susceptibility to arrhythmias is also present in complex conditions, including coronary artery disease patient. But what we have is a well-defined type of inheritance patterns and identified culprit genes. We will look into some of those. And this is a big tragedy that we see, especially sudden death with some of the celebrities or sports activity, young, otherwise very healthy people who suddenly just collapses with cardiac arrest. And most of this is related to ventricular tachycardia and ventricular fibrillation. And the real challenge become how we can identify these patients who are at risk and do something to prevent before this life-threatening event take place. And a lot of progress has been made in understanding of these syndromes, from definition of the conditions and identifying all the molecular basis, and now attempt towards engineering those cells to rectify the problem. So let's focus on some of the common mechanism and how we can identify these patients. So for cardiac arrhythmogenesis, I think, again, we'll have to go back to the substrate, and the substrate could be an anatomically determined substrate in young patients with scarring in the heart, or hypertrophy and disarray with hypertrophic cardiomyopathy or ARVC, or functional defect that we see with ion channel mutations that results in either loss or gain of function, resulting in a substrate that then could be modified by modulating factors. So the presence of substrates increasing the susceptibility, but these modulating factors are those that can then trigger and make the substrate more unstable to cause the abnormal automaticity, triggered activity, or reentrant arrhythmias. So both the genetic and the substrate and the modulators are under genetic and environmental type of influences. And it is important to recognize both of these factors especially for preventing sudden death events or high risk type of situation in family members. It's very important to know what are the genes that are involved, and then to modulate these environmental factors. So there are more than 40 different genetic heart diseases that have been identified. For our purpose today is inherited cardiomyopathies, such as hypertrophic cardiomyopathy, which prevalence is almost like 1 in 200 in the population. And in South Asia, it appears to be higher than what we see in other parts of the world. And similarly, inherited arrhythmogenic syndromes are something that are common, especially the long QT syndrome. And what I hear from colleagues from Pakistan, the Brugada syndrome is also quite common. So we will focus more on these two major ones, and then we'll cover some of the other ones if time permits. And there are thousands of causative gene variants. Most common genes identified are typically transmitted more in a Mendelian fashion. Most of the sudden death syndromes are transmitted as autosomal dominant. A few are autosomal recessive. Very rare are X-linked. And then not to forget that the complex traits, even with patients with ischemic heart disease, VF, there are the ion channel or the channelopathy related players are involved in this interaction of environmental factors with the arrhythmia that take place in these patients. And susceptibilities in families have been well recognized in structural heart disease patients, not typically thought to be of Mendelian in nature. So if we look at inherited arrhythmia syndrome that increases risk of sudden death in young patients, broadly, I think it's easier to classify them into those with structurally normal heart with primary electrical disorders, and some of those are listed here that we will review. And those with structural heart disease, especially hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy syndrome, dilated cardiomyopathy, the newly recognized entity of, it's not newly recognized, it is again going back to some original to recognize the malignant mitral valves prolapse syndrome patients. And then so the primary electrical disorders of the heart that I'll focus on, which are mainly related to functional defects in ion channels or regulatory proteins, or so-called channelopathies. But what's important is that predisposition to induced arrhythmias, particularly drug-induced arrhythmias, are also probably related to these concealed form of channelopathies that are unmasked when exposed to drugs or ischemia. And there are certain ion channels that are involved in ischemia-induced type of VTVF, which increases predisposition in certain families and other complex acquired disorders. So the whole field is evolving, and we are learning more and more as the number of genes are expanding. Also, the number of genes that are actually disease causing is also shrinking. So a new relook in those underlying predisposition etiologies are being considered now. So starting with the most common disorder, the long QT syndrome, and as all of you know, it's a heterogeneous group of disorders. It's not a single condition, but the common manifestation of prolonged ventricular repolarization in structurally normal heart and a high risk of malignant ventricular arrhythmias that has a characteristic morphology of this torsade de pointe. So here is a rhythm strip of a young patient presented with syncope in the ER with prolonged QT interval, and then PVC initiated this polymorphic twisting type of VT, frequent PVCs that you see in these patients. And so this is most common cardiac channelopathies, and I'm sure everyone in the audience have seen one or the two cases, both in congenital and familial form or the acquired form, which is some people feel like that it's a form fruste of the congenital form or the concealed form that might be exposed when it's exposed to those factors that unmask the underlying pathology. So this is the classical type of classification. The autosomal dominant form is the more common form. It's 1 in 2,000 live births have been estimated to be the prevalence associated with normal hearing, and it is used to be called Romanov-Wart syndrome. And then the recessive form, which is quite rare, you need to have 2 hits in the genes, and the genes that have been described commonly are those that codes for the IKS potassium channel subunits, the Jarvell-Lang-Nielsen syndrome. And since this potassium channel is present in a rare, the formation of endolymph congenital deafness is associated. So these are some of the findings that you, during history taking, you ask in families if they have young children with congenital deafness or family history of sudden death syncope. And the sporadic form, the acquired forms are those, and we have talked about it in the past also, drug-induced is a major problem in the society that we have little understanding of with common drugs like antibiotics and tricyclic antidepressants. How big is this problem where it causes a sudden death syndrome in otherwise young patients? So 17 genes have been associated with the long QT. The 3 which have definitively been linked are those in this common forms of long QT, which is the KCNQ mutation, IKS. 2 potassium channel are the most common one. The 3rd common one is in the sodium channel. And then some of these patients who are asymptomatic may also have concealed long QT without QT prolongation on their ECG, but have underlying genetic susceptibility. And the mechanism of, this is more for the general cardiologists and the students in the audience. Whenever you're thinking about the QT interval or action potential, think about the inward current and the outward current. So mainly the QT prolongation occurs if there is a gain of inward current. The sodium channel and calcium channel will cause QT prolongation, which has a different phenotype and presentation than those that presents with loss of function or repolarization prolonging type of abnormalities. And the common 3 potassium channels, the top 2 are the IKS and IKR mutation, but other potassium channels are also involved. Don't forget the potassium channel blockers, whether antiarrhythmic drugs or erythromycin and levaquin that you use, also has this influence on QT and can cause presentation and precipitate arrhythmias in these patients. So the top 3, as you look at it, the most common form is the IKS or non-QT type 1, 50% of the patients, and then 30 to 45% have long QT 2 and 5 to 10%. The remaining are all extremely rare. So of all genotype patients, about 75% of the patients have identifiable genetic defect, but 20 to 25% may be genotype negative. So these genes are now questionable. They are not linked as closely as these others are, which are thought to be more definitive linkage in studies that have been done. So there's a reanalysis going on of association studies that have been reported in the past. So the substrate alone is not enough. You know, patients are born with a mutation with loss of function of potassium channel or gain of function of sodium channel. On top of that, there are triggers that can precipitate this early after depolarization and reentrant type of arrhythmias that then precipitate the torsality point. So when you're thinking about management, both substrate and triggering factors are critical. These PVCs, which, you know, like a surrogate of these EADs, you have to identify, and in refractory patients where nothing is working and ICD shocks are a problem, this may become a target for ablation type of a modulation of the substrate to reduce the burden. The common presentation is that of syncope, and you can see that the blood pressure drops with these short runs, and these are otherwise healthy hearts, so they recover from this polymorphic VT short runs enough to cause hypotension and syncope. recurrent syncope. And if it's prolonged, then sudden cardiac death can result. So the clinical presentation is variable, so depending on age, gender, genotype, environmental factors, and the presence of therapy and modified genes, it can modulate presentation. Majority of patients, especially the long QT3 patients, are asymptomatic, and long QT1 have more of those patients have symptoms. This is also at least all of these are life-threatening conditions, but less malignant than the long QT and long QT3. Symptoms vary from palpitation to sudden cardiac arrest, typically precipitated by specific factors, and there are some genotype-phenotype correlation that have been identified in terms of triggers for these arrhythmias. They have PVCs on rhythm monitoring, and you may identify some torsade de pointe type of event. The main concern with all these arrhythmia syndrome is that of sudden cardiac death, which could be the first manifestation in up to 10 to 15% of the patient. So majority of the patients will have some syncope or palpitation, but there are some of these where first event could be life-threatening event. The risk stratification is very important, and it's an evolving area. The risk is low, 0 to 40 years, 4%, but among those who have recurrent syncope, the risk is much higher. And the risk increases with medications that further prolong QT interval, electrolyte abnormalities, and certain stressors that we talk about. And ECG has variable QTC prolongation based on the penetrance of these defects, and the expressivity is also variable, resulting in variable QTC prolongation and structurally normal hearts. So it's important to know some of the genotype-phenotype characteristics, and nothing is absolute, but if you look at the common forms of the triggers that causes lethal cardiac events, exercise, emotion, and rest, you see that the long QT type 1 presents more during exercise, swimming being a major trigger. Whenever you see a patient with drowning or swimming type of loss of consciousness issues, think about long QT type 1. CPVT will be the other conditions to think about. Emotion-related type of arrhythmia you see more with long QT type 2, and rest or sleep type of event during night, nocturnal death, sodium channel is more involved. The sudden alarm-related syncope or loss of consciousness or telephone ringing at night precipitating an event you see more with long QT2, which is also seen in the postpartum setting. You see more problem with long QT2. So that genotyping is important, and we may not have time to go over the pros and cons of genetic studies, but in at least long QT patient and some of these arrhythmia syndromes, it's important to have a strong genetic lab and counseling service available to manage these patients. Sleep related in long QT type 3, there are certain ECG characteristic associated with the genotype. This is nothing is absolute, but in long QT type 1, there is broad-based type of T waves that you see. Long QT2 has these low amplitude, but a notched type of T waves. And in long QT3, there is longer ST segment with normal looking type of T waves, but QT prolongation mainly in the ST segment. The other test and physiology, and we don't have time to go over the provocative type of testing, how to identify the underlying defect or to differentiate between one versus other genotypes based on some clinical bedside type of maneuvering. But QT shortening with increased heart rate is the normal adaptation of the heart. So this is refractoriness adaptation that we see with tachycardia, allowing the heart filling of the ventricle and other adjustments. So this is impaired most prominently in long QT type 1. And this is the basis for the epinephrine challenge or the exercise test or the standing test that people have proposed to identify and these syndromes. Here is epinephrine challenge. Normally, the QT interval shortens. It paradoxically prolongs with heart rate increase, whether it's exercise, epinephrine, and this is direct effect on the IKS effect, which is impaired in loss of function mutation, causing paradoxical QT prolongation, most probably seen for long QT type 1 loss of function mutations. The other helpful feature of this type of correlation of genetic effect is on effectiveness of therapies, especially beta blocker is most effective in a condition where sympathetic drive is the actual IKS responds to sympathetic stimulation. So if you take away the function of IKS and this sympathetic modulation of the QT interval, that's where the beta blocker are most effective. Paradoxical prolongation and EADs could be inhibited more effectively. But beta blockers are effective for all three types with variable type of efficacy. And it is the first line therapy for all long QT syndrome patients. The good thing is that in patients who are on beta blockers, syncope usually precedes cardiac arrest. So the first line therapy with beta blocker, unless somebody has already presented with cardiac arrest, and if you cannot afford to get an ICD in remote places in Pakistan, at least they should be on a good high dose of maximum tolerated beta blocker. And we'll talk about sympathetic denervation that also is effective in these patients. So how do we diagnose a QT interval? This is for the cardiology fellows and for internal medicine colleagues. So this is the distribution. This curve was generated by my colleague at Mayo, Dr. Ackerman, and he has contributed so much to this field, is where he showed that the normal distribution of QT interval, this is the normal QT for women that has been described, and 440 is there. But if you keep on looking at the 99th percentile of the 480 milliseconds for female and male is what we see. So the upper limit, and this is how the long QT has been described. So diagnosis of long QT syndrome require a QTC interval with normal QRS, obviously, of more than 500 milliseconds, or QTC greater than 480 milliseconds, but presence of symptoms gives you a diagnosis of long QTS. And there are three ways you can diagnose this. One is looking at ECG, and ECG may not give you prolonged QT, as we will see. Then you can use a clinical diagnostic criteria that was proposed by Dr. Schwartz a while ago and still has validity in identifying high probability patients with long QT. Based on clinical history, family history, and ECG finding, the scoring system was proposed. And for QTC interval, QTC recovery after exercise, torsad, other T-wave repolarization abnormalities, alternance or notch T-waves, low heart rate for age. There are certain scoring that has been given. And among history, syncope with stress, without stress, and family history of long QT as all compromise the scoring system, greater than 3 being high probability of long QT. And overall, the system works well and can identify long QT syndrome carriers with sensitivity of 89, specificity of 82%. So using all of these tools is important. And the most important tool that we now have is this is now the guidelines. Any three of these gives you a diagnosis of QT, long QT syndrome, QTC greater than 47 for 80 millisecond in repeated 12-lead ECGs, the score of 3, or a pathogenic mutation in long QT syndrome genes in respective of QT interval. There are a number of concealed long QT patients with normal QT interval, but with the abnormal gene who are at high risk for arrhythmic events when exposed to the second hit, a drug or low potassium or catecholamine type of surges. And in patients with unexplained syncope with QTC greater than 460 milliseconds repeatedly in the absence of a secondary cause, the suspicion is high, and these patients should be considered for further assessment by genetic testing and repeated monitoring of the ECG. And with the long QT, genetic testing, we have now identified that these are all genotype positive patients, and you can see their long QT, their QT interval varies from pathological very high range to all the way to very normal range. And this group of patients who have the positive genes, but negative phenotypes are those genotype positive, phenotype negative patient. And these are those who have the concealed long QT syndrome at risk with arrhythmias. And this is mainly related to incomplete penetrance and variable expressivity of the abnormal genes that can conceal the ECG pattern normally we recognize with long QT, but the risk for arrhythmia is high. And these numbers are not small, especially for long QT type 1. Now, recent studies suggest that the numbers are up to 40 to 50% of these patients may have concealed long QT. So same for long QT2, substantial number of patients have concealed forms, and genotyping helps identify and then help us at least modify lifestyle factors. Avoidance of certain drugs becomes important part of management. And the yield of genetic testing, I'm spending more time on long QT as a approach that we use for all the genetic arrhythmia syndromes, where long QT being well studied. So out of all the genes that you saw, 3 genes are responsible for 75% of the genotype patients. The other, 15 genes or 14 genes add another 5%. And the association of some of these genes are being reassessed. And the likelihood of identifying a mutation increases as the QT interval is longer and the short score is on the higher side. So selection of whom to select for genetic testing is another thing to the clinical suspicion to confirm that the diagnosis and the family member with a positive genetic test in the proband are the patients who needs to be tested. What need to be remembered there is that the negative genetic test with a clinical long QT syndrome does not exclude the diagnosis. Genotype negative and phenotype positive patients are typically the one that are sent to us to further assess what to be done with these patients. How do we manage long QT? So, this depends on their presentation and underlying acute interval. Those who present have declared themselves with cardiac arrest. Beta blocker is an essential part, reduces event rate, but they still have breakthrough arrhythmia, so ICD is indicated if they are candidates for that. And for recurrent ICD shocks, either a sympathetic denervation, addition of drugs like mexiletine, and there are some data emerging about some other sodium channel blocker if they can help. For the QTC between greater than 470 and symptomatic patients with recurrent syncope or palpitations, again, beta blocker should be given to all of these 3 groups of patients: those with primary event, those who are at risk, and those who otherwise are asymptomatic and not considered very high risk, class 2A indication. If they have persistent symptoms or have high risk features, and high risk features have been variably defined, but those with excessively prolonged QTC, genotype long QT2 and 3 are more malignant than long QT type 1. Females with long QT2, younger age or onset of symptoms, especially earlier in age, less than 10 years or first years of life, are particularly at high risk, and those with recurrent syncope. And a treatment intensification includes cardiac sympathetic denervation, adding more medication, and ICD is indicated if could be implanted. Those patients who are asymptomatic but excessively prolonged QT, they are at high risk for future arrhythmic events. And in addition to beta blocker drugs, but under the supervised expert type of setting, drugs like mexiletine may have a role, but we have to be cautious. Not very well studied, but promising preliminary data is out there. Sympathetic denervation or even ICD in high-risk patients. And the main, I think, issue to address with all these patients is avoidance of QT prolonging drugs and other precipitating factors. This is a good site where they keep updating the drugs which are known to affect or probably can affect QT interval and which drugs are safe. Particularly becomes a problem with patients with depression and where SSRIs and TCAs all have QT prolonging effect. Patients with oncology type of issues where there are a number of medications that prolong QT, and then the anti-nausea drugs adds to the QT interval. So it's a real challenge, and that's where we have to be careful how to manage these patients. Sports is another question these patients ask. And that's where I think it's sitting down with them and going over their genotype, especially for long QT type 1, and other is important to go over with if these are pediatric patients, with their families and parents to understand what is the risk. And it's not that it's prohibitive for all of these syndromes, but at least the risk benefit needs to be reviewed. And the other question is the beta blocker, what to use. And Nerolol is preferred because of its long-lasting effects, non-selectivity, but it's not available in a lot part of the world. So propranolol is another drug. The main issue has been that this has not been very well studied. And whatever meta-analysis we have, Nerolol and propranolol come out to be better because it has been used by those experts setting and referral centers, so we have more data on that. Metoprolol is also effective. Atenolol has some effect, but not the first line. So it's important to be on a long-acting medication. The evaluation of patient and family member with sudden death syndromes is very complex, and it requires a multidisciplinary team approach. It's not a single face-to-face, talk with the patient and families by the electrophysiologist. Involve your genetic counselor with it, the nursing service, as well as a primary cardiologist. And it's a very, thorough evaluation that we have in our channelopathy clinic that, we don't have time to go over, but all of this thing helps with the diagnosis and risk stratification. Genetic testing, its interpretation is very important, and counseling before and after is important. And management and counseling is an ongoing process that we review with these patients in the clinic. Genetic testing also is updated. So variant which was of uncertain significance may become benign or rarely malignant. So all of this information has to be updated. So the other common syndrome, I think, is important to.
Sorry, if we are running short of time, so if you wanted to next 5 minutes, please.
Okay, so I think the Brugada syndrome is important. Let's just, it's not that long. So the Brugada syndrome, I think you all know, it's a characteristic ECG, ST elevation in the right precordial leads, autosomal dominant, 23 genetic variants, but the most definitive cause is SCN5A. Prevalence is high, especially in Southeast Asia and Asia. And what I've learned in Pakistan also, the prevalence is high. Male predominance, arrhythmia, third to fourth decade of life, and sudden death during sleep. So this is an ICD shock during midnight. So I think there the diagnostic feature for the cardiologist to pay attention is to look at the morphology of this J-point elevation, this cove type with this negative T waves is the diagnostic, what's called type 1. There is a dynamic change from type 1 to type 2 in the same patient. So here, this is the type 2 saddle shape type of with greater than 2 millimeter or less than 2 millimeter type of ST elevation. These are not diagnostic. So you have to have type 1 to call it Brugada type ECGs. It could be spontaneous and provoked. And this is where the evaluation is important by your electrophysiology colleague. Structurally normal heart, and this is associated with polymorphic VT or ventricular fibrillation, family history of sudden death in young patients, and family history of Brugada-like ECG. It's a dynamic change in ECG. So if you have a normal ECG, this is a patient 1 month after cardiac arrest in this 15-day. So you don't be fooled by this ECG. They need to have assessment of ECG or some provocative type of test with intravenous sodium channel blockers. In this study, this was Ajmaline. In United States, we don't have we have only procainamide intravenously. So that's what we used for identification of this type 1 ECG. And the lead placement is important when you are assessing these patients. High leads will give you a better appreciation of this type 1 type of ECGs. So clinical presentation is variable. And I think the main thing to remember is that sodium channel blockers or those with sodium channel blocker effect like the antidepressants, vagotonic drugs and fever can precipitate that. So it's important to manage these conditions and avoid these drugs as much as you can. So the main markers for increased risk of sudden death, are the previous history of cardiac arrest, syncope, or spontaneous ST elevation. These are the 3 main markers of high risk. Other markers are controversial, including EP study. Inducibility it has a role, but it's not clear. The sensitivity and specificity in experts' hands is better, but be careful. The major problem become what to do with, and this is what happens in that fever-induced type of Brugada patients you see in the ER, what to do with that. They never had syncope, there is no family history of sudden death, and that is a controversial area. There are certain accepted risk factors like type 1 spontaneous ECG, independent of fever, EPS, again controversial, but if they have an induction with 2 extra stimuli, it's considered high risk by some individuals. Ventricular refractoriness, very short ventricular refractoriness, sinus node dysfunction, QRS fragmentation, or abnormal signal average ECGs. And controversial risk factors, again, whether fever-induced type 1 ECG has a prognostic influence, it's not very clear. There are other risk factors that have been identified. The family history of sudden death or presence of the sodium channel mutations is not clear. They are controversial. I think most of the people don't take this only as a reason to implant an ICD or high risk factors, but this data is also evolving. So far, this is considered as poor predictive value. And the management of this, again, for arrhythmia patients who have cardiac arrest is ICD. Quinidine is the drug. If you can't implant ICD or you have recurrent shocks on ICD, quinidine works well. And there are certain reasons why quinidine is better than other drugs. EP study is, again, a class 2B indication for patients who have not had cardiac arrest or syncope, asymptomatic patients. If they have inducible arrhythmias, ICD is indicated, class 2B indication. Genotyping in spontaneous type 1 is class 2B. If they have positive, especially a CN5A mutation, then genetic counseling should be done in all relatives. And the lifestyle changes and avoiding aggravating drugs, treating fever, avoiding excessive alcohol, cocaine are all important part of the management. This is the site where you can get those drugs which affects the ECG or Brugada type of risk factors. How much time do we have? I think I have only a few slides. CPVT, I think do we have time?
So Dr. Arshad, we are already behind by about 15-20 minutes. So okay. If you can finish quickly, we'll have 1 or 2 slides.
Okay, so the CPVT I think is important because it's seen in young patients with not structurally normal heart. And they have a normal resting ECG. So you don't have ST elevation or QT prolongation in these patients. And mostly it's a clinical diagnosis induced by physical or emotional adrenergic stress, and that can precipitate ventricular tachycardia. Prevalence is estimated to be 1 in 10,000, but under-recognized, so it's not clearly known. Prognosis is poor. This is one of the serious conditions, with 15% of unexplained sudden cardiac death could be, especially exercise-induced on athletic field or swimming-related death. Suspicion should be high. And this can be diagnosed during exercise test. There is, if you exercise beyond certain threshold level, you start to see PVC appearing during exercise that degenerates into more complex PVCs, bidirectional PVCs, and then polymorphic VT or VF. And as you stop the exercise and during the cool down, you start to see arrhythmia organizing, bidirectional VT, and beyond that threshold, then go back. So the gold standard for diagnosis is exercise test, and bidirectional VT you don't see all the time, but if you see it in a young patient, that increases the probability of this condition. Isopaternal challenge also can reproduce these findings, bidirectional VT, polymorphic VT, VF. And I think the most important part of diagnosis is the documentation of this reproducible, which is quite reproducible in these patients of adrenergic sensitive exercise, motion, catecholamine of this polymorphic bidirectional VT, rule out structural heart disease or coronary artery disease and other primary electrophysiology disease. There are several pathogenic mutations that have been identified. Ryanidine receptor is the gene, is the calcium release channel, which is the common culprit in these patients. Both autosomal dominant and recessive forms, especially with calsequestrin, have been identified. The family members of a CPVT patient with a structurally normal heart also should be evaluated by exercise test, and if they have pathogenic mutation with the genetic test. Lifestyle modification is the main, I think, important factor. Beta blockers are important, natalol preferred or propranolol if you don't have natalol. ICD implantation if they continue to have syncope despite beta blocker. Left sympathetic denervation is also something that works. Flecainide is an important tool in these patients. It inhibits the ryanidine receptors and can help. Beta blocker and flecainide combination is a good combination for these patients. Class 2B indication, left cardiac sympathetic denervation has a 2B indication. And what should not be done is that ICD should not be given as a standalone therapy. It can result in more proarrhythmia, especially with the fear of shock, and catecholamine, it can cause problem. Inappropriate shock with T-wave oversensing is also a problem. And EP, as for program stimulation, is not indicated. So I'll stop there, and if there are any questions. Sorry, it's a very long and
Absolutely.
We really appreciate, we know that it's a very, very long topic, and you've done justice to it.
Thanks for an excellent talk, Dr. Jahangir. This is wonderful, and always listening to you about these genetic arrhythmias is a privilege. Many thanks. We'll take questions at the end because we are also running behind. So next speaker, may I ask Dr. Intisar to please introduce our next speaker?
Okay. Thank you, Dr. Yavar. It is my pleasure to introduce Dr. Faisal Qadir as next speaker. Dr. Qadir is a graduate of Bakai Medical College, and he holds certification in medicine and cardiology from College of Physicians and Surgeons, Pakistan. Dr. Qadir has the distinction of being trained as the first fellow in cardiac electrophysiology in Pakistan, and later on he underwent advanced training in EP at National Heart Institute, Kuala Lumpur. He is certified from International Board of Heart Rhythm Examiners in devices as well as in electrophysiology, and currently he's working as an assistant professor of cardiology and consultant electrophysiology at National Institute of Heart Cardiovascular Diseases, Karachi. Dr. Qadir is going to talk on electrical storm, management and outcomes. We welcome Dr. Qadir, and over to you, Dr. Faisal.
Okay, thank you very much, Dr. Intisar, and I really thank the organizing committee for the kind invitation. I hope my slides are being showed. Huh?
Yes, we can see your slides.
Okay, thank you so much. So the topic I've been given is the electrical storm, and the term kind of sounds a bit overwhelming. So it refers to a clinical scenario in which there are recurrent episodes of multiple ventricular arrhythmias in a short duration of time. The presentation can be a devastating event and is associated with worse short-term as well as long-term mortality. When it comes to the defining electrical storm, it depends upon if the patient has an ICD or not. In patients who don't have an ICD, it's usually 3 or more discrete episodes of arrhythmias, ventricular arrhythmias over 24 hours period. And in patients who have ICDs, it's 3 or more episodes of ventricular arrhythmias over 24 hours, treated either with ATP or ICD shocks, with each event separated by at least 5 minutes. So they want a period of sinus rhythm in between these episodes. Predominantly, it will be a presentation with monomorphic VT, and we know that patients who have prior MI and SCAR, they have these areas of slow conduction, and that can be the substrate for arrhythmias. Less commonly, maybe approximately 3 to 8% of the patients present with polymorphic VT or VF. And when that is the case, usually the differentials are very narrow. So you have to rule out acute coronary ischemia, electrolyte disturbances, prolonged QT interval, and as Dr. Arshad alluded, genetic channelopathies usually present with polymorphic VT-VF. When it comes to the predictors of electrical storm, in one study, it was shown that male sex, advanced age, presence of other medical comorbidities, patients who have secondary prevention ICDs and prior treatment with class 1 antiarrhythmic drugs, these are the patients who have more presentation with electrical storm. It is not uncommon, and patients who have ICDs for secondary prevention, they will 10 to 20% will experience electrical storm within 2 years of ICD implant. It is lower in patients who have primary prevention indication for ICD, and it's approximately 4% over an average of 20 months. Similar slide had been shared by Dr. Jahangir. So the pathophysiology is an electrical triad among 3 things. So you have to have an electrophysiological susceptible substrate, either in terms of a myocardial scar or an arrhythmia syndrome. Then you have to have triggers like ischemia, infection, electrolytes, toxins, and the role of autonomic dysregulation. So usually patients have a reduction in the parasympathetic tone and a surge in the adrenergic stimulation, which tips them into a storm. The clinical presentation can be variable, and sudden death may actually be the first presentation. And patients would present with symptoms of congestive heart failure. The patients who have ICDs may just be asymptomatic because a lot of the arrhythmias were successfully treated with ATP and they don't have shocks. But on the other hand, they can have recurrent ICD shocks, and we also, as electrophysiologists, know how helpful unhelpful or so we get when treating these patients with recurrent ICD shocks. The approach to management would really depend if the patient has an ICD. If the patient does not have an ICD and the first presentation is of an arrhythmia, very important to look at a 12-lead ECG and rule out other causes of wide complex tachycardia. So you should make sure that the patient has ECG diagnosis of ventricular tachycardia before proceeding. A multifaceted approach with thorough clinical examination, resuscitative measures are important, and sedation, medical therapies, and I'm going to highlight all these in the future slides. So the initial assessment, the paramount thing is to determine the patient is hemodynamically stable or unstable, and if it's hemodynamically unstable, then institution of ACLS is mandatory. Look for reversible causes like ischemia, electrolyte disturbances, and special scenarios call for specific management. Like patients who have idiopathic ventricular fibrillation, targeting the culprit PVC may really improve the mortality of these patients. So catheter ablation has a role in these patients. Long QT, Brugada has been discussed by Dr. Arshad. Brugada, the role of quinidine, as mentioned, and patients who have ARVC and cardiac sarcoidosis. So the shift will more be towards a catheter ablation of their epicardial substrate. Comes to medical therapy, antiarrhythmics are the backbone, but they have not been shown to impact on mortality. So they significantly reduce ventricular arrhythmia recurrence. Beta blockers, recent study showed that the use of non-selective beta blockers like propranolol was much better than compared to metoprolol in reducing the episodes of ventricular arrhythmias, and these patients spend less time in the ICU. So propranolol definitely has a role in VD storm. Amidron, we all know, has a class effect, multiple channel blocking abilities. Lidocaine has a niche role in patients who have ischemic VT. Sedation is important just because adrenergic tone is so high. ICD shocks in turn give a lot of adrenergic stimulation, so the patient has to be sedated. Preference should be given to opioid analgesics and benzodiazepines. Propofol has a negative inotropic effect, so it should be avoided. The patient has an ICD, so device reprogramming makes sense. The first thing would be to see if the ICD therapies are appropriate or inappropriate. And if it's an inappropriate therapy, the ICD is firing a lot, then you need to turn off the ICD and deactivate therapies. And a magnet can be applied on top of the device if the programmer is not available immediately. If the ICD therapies are appropriate, still it should be deactivated and other measures should be taken to kind of calm down the patient. We know from trials that programming longer detection times and enhancing ATP therapies in ICDs should be done. And sometimes the few patients who have CRTs, and sometimes the onset of LV pacing can be proarrhythmic, and that may sometimes trigger these patients into electrical storm, and there have been case reports. So that needs to be turned off if that is the case. Very good data now for suggesting the role of autonomic modulation, and again, it's targeting the adrenergic surge. So different ways that can be considered are thoracic epidural anesthesia, and we can use our get the help of our anesthesia colleagues in doing this, and you inject bupivacaine in the epidural space. The other one can be a stellate ganglion block, and this is a rather simple process. It can be done at the bedside. So just palpate the cricoid cartilage, displace the vascular bundle, and just go straight perpendicular into the stellate ganglion and inject bupivacaine or maybe lidocaine as well. It can also be done with the ultrasound approach, and it is can be done at the bedside. You can use the surgical expertise and go for thoracoscopic or open cardiac sympathetic denervation, in which the lower half of the stellate ganglion and T2 to T4 ganglions are removed. The role of catheter ablation, it finds a role in patients who have refractory VT despite medications and other side effects from the drugs. It has established a role superior to medical therapy in multiple trials in showing reduction in arrhythmia recurrence and ICD shocks. And the meta-analysis reported that after 1 year, more than a year of follow, 83% survival and 60% freedom from arrhythmia recurrence was there with catheter ablation. But the trials that have been done are not large-scale multiple randomized trials, and they have not yet shown a mortality benefit of catheter ablation in electrical storm, but certainly it reduces ICD shocks and arrhythmia recurrence. Patients who have polymorphic VT and focally triggered VF, catheter ablation does have a role in improving mortality in these patients. When to refer patients? Study by the Penn group, they recommend earlier referral to catheter ablation resulted in better 1 year VT-free survival. The role in non-ischemic cardiomyopathy of catheter ablation is less prominent. The HELP VT, the German study, they reported that non-ischemic patients, the outcomes were not as good as ischemic patients. Just because the substrate is so widespread, you sometimes require epicardial ablation, hence it's not good. But recent data from another study reported a good success rate similar to ischemic cardiomyopathy patients. When traditional endocardial and epicardial catheter ablation fails to prevent recurrences, you can use a novel alternative technologies like half normal saline irrigation, bipolar ablation, needle ablation, and sometimes a coronary sinus ethanol infusion to target VTs in these patients. The role of hemodynamic support, it's a very sick cohort of patients, and circulatory support in terms of ECMO and LVAD is very useful. And patients who are undergoing catheter ablation support with PLVADs has shown that it results in a safe procedural completion of these patients. As far as outcome is concerned, it's a critical moment. Electrical storm is a critical moment in the progression towards irreversible heart failure, and it may actually constitute the initial manifestation of a worsening heart failure. It's a strong mortality risk factor associated with an increased combined risk of death, heart transplant, and hospitalization for heart failure. So in conclusion, I'll say that electrical storm is a cardiac emergency that requires swift intervention, and it is associated with poor short and long-term outcomes. And recent research could modify the management of electrical storm, supporting the role of non-selective beta-1 and beta-2 blockade, the early intervention with catheter ablation, as well as the strengthening role of cardiac sympathetic denervation. And while we have come a long way over the last few decades, further research would be paramount to improve the outcome of patients with electrical storm. Thank you very much for your attention.
Thank you, Dr. Qadir, for a comprehensive overview of VT storm and its management. For the interest of time, I think we are not going to take questions here, but I just want one comment from Dr. Ashraf Dar. He is one of the pioneers of EP in Pakistan. I would like to hear from him his input on VT storm outcomes in Pakistani population. Dr. Dar, if you can hear me. I think Dr. Dar cannot hear me, so I would like to hand over to Dr. Amir for next session. Thank you, Dr. Faisal.
Thank you, Intisar. It gives me pleasure to introduce the next speaker, Dr. Ahmed Eldamaty. He's an associate professor of cardiovascular medicine at the Cairo University. He's a consultant clinical cardiac electrophysiologist in pacing. He's among the few physicians experienced in this field in Egypt and the Middle East. Dr. Eldamaty graduated from the Cairo University back in 2001 and then went on to the QE2 Health Sciences Center, Dalhousie University, Halifax, Canada, to do a 3 years advanced level fellowship. He's a fellow of the European Society of Cardiology and Egyptian Cardiac Rhythm Association. He's the head of electrophysiology services at the Cairo University Hospitals, Arab Contractor Hospitals, and he's attending at the Darul Faoud Hospital and As-Salam International Hospital. He has several national and international publications to his credit. He has organized and chaired several national and international conferences in collaboration with the Egyptian, Lebanese, Saudi, and European Societies of Cardiology. Dr. Eldamaty is one of the pioneers of complex mapping and ablations in Egypt and in the region. I feel pleasure in stating that, Ahmed and myself, we shared an office while we were overlapping in our fellowships, and he's very good with ECG, and we used to have a lot of debates. So I'm sure you're going to enjoy the talk. He's going to talk about idiopathic ventricular tachycardia. Ahmed, over to you.
Thanks, Amir, for this nice introduction. And again, it's a pleasure and honor to have the opportunity to be among you today. If I can be granted access to share my slides, that'd be great.
Dr. Qadir has to unshare his screen before you could share your screen, Dr. Eldamaty.
Okay.
Request Dr. Faisal Qadir to unshare his screen.
Okay, I'll be doing that.
Thank you. Ahmed, try now. Yes,
So
we
I
have your
hope you
screen. We
Okay,
can see.
good. So I'm going to talk today about idiopathic ventricular tachycardia, its ECG patterns, and how we manage it. And so in terms of disclosures, there is nothing relevant to this presentation. And I'm going to get ahead and cover these following objectives. So what's the site of origin of idiopathic VT? What's its mechanism? How we can localize it using electrocardiogram, and how can we manage it? So this is the time-honored classification of idiopathic ventricular tachycardia that could be classified according to the mechanism into triggered activity that's usually adenosine sensitive, or re-entry that's usually verapamil sensitive. Adenosine sensitive triggered activity, idiopathic VT, can basically arise everywhere, but there are common sites. So the common sites being the right ventricular outflow tract, the left ventricular outflow tract, be it from the left or the right coronary cusps, or the coronary venous system, or the left ventricular anterior epicardium. There are other less common sites like the basal left ventricle, or the papillary muscles, or the right ventricular inflow tract. So the reentrant type of idiopathic VT is usually verapamil sensitive, and it's namely the left ventricular fascicular VT that can be related to one of the fascicles, whether it's the left anterior fascicle or the left posterior fascicle in the left ventricle. So what about the ECG localization? The ECG localization, we can basically resort to the basics. So these apply to most of the arrhythmias, and namely for the ventricular arrhythmias. So when you look for the bundle branch block, if it's left bundle in origin, you know you're probably originating from the right side of the heart. If it's right bundle in origin, you're probably originating from the free wall of the left ventricle, where the precordial transition usually points to whether it's apical or basal in location. So foci that originate close to the apex of the heart, to the base of the heart, usually have a positive concordance in the precordial leads, while those that originate near the apex of the heart usually have a negative concordance. And that depends mainly on the direction of depolarization, and whether it's going towards the lead, thus drawing a positive deflection, or away from the lead, thus drawing a negative deflection. The QRS axis can tell us whether it's originating from the anterior wall of the heart, if it's inferiorly directed, or whether it's originating from the inferior wall of the heart, if it's superiorly directed axis. The QRS wedge always points to the septal location when it's narrowish, and points to a free wall location when it's rather more wide. So these are the basic principles. In this presentation, I'm going to focus on the idiopathic VT that has a left bundle branch block configuration, and the inferior axis being the most common. So those would arise from the right ventricular outflow tract, the pulmonary artery, usually the left, sinuses of Valsalva and the aortic root, the left ventricular outflow tract, the area of the LV summit, coronary veins, usually the junction between the anterior interventricular vein and the great cardiac vein, or the anterior epicardium. So in order to understand this complex part, we need to focus on the anatomy a little bit. So this is the aortic root. You can consider it in a cross section of the heart, the middle of the heart. The aortic root has those both sinuses, the left sinus from which the left main originates, the right sinus from which the right coronary artery originates, and they are rather anterior structures. So posterior to those are the non-coronary cusp, which is usually related to the interatrial septum and does not get involved into the origin of ventricular tachycardia. Anterior to this structure is the right ventricular outflow tract. So contrary to the perhaps a possible belief that the right ventricular outflow tract lies to the left, whether the left ventricular outflow tract right to the left ventricular outflow tract is to the left of it, it's actually rather the other way around. So at the origin of the outflow tracts, the right ventricular outflow tract bears an anterior location, where the left ventricular outflow tract is posterior to it. As we move further away from the heart into the great vessels, the right ventricular outflow tract gets directed a bit to the left, and the left ventricular outflow tract gets directed a bit to the right. It's really important to realize this relationship so that you know that there is a close proximity of the posterior part of the right ventricular outflow tract to the left coronary cusp and the right coronary cusp. So this is another orientation where you can see the root of the aorta in the middle of the heart. The right ventricular outflow tract is anterior to it. The interatrial septum is posterior to it. The left coronary cusp and the right coronary cusp bears close proximity to the posterior or the septal portion of the right ventricular outflow tract, which is a common site of origin of PVCs or idiopathic ventricular tachycardia. So having said that, there is another relation that needs to be put in mind, which is the relation between the anterior interventricular vein as a continuation of the great cardiac vein and its close proximity to the to this area of the right ventricular outflow tract, left ventricular outflow tract. So if you can see here, this catheter being advanced into the coronary sinus, into the distal coronary sinus, this decapolar catheter, you can see it very close to a catheter that is put retrograde through the aorta in the left coronary cusp, and again rather close to a catheter that is put through the femoral vein, tricuspid valve, and then to the right ventricular outflow tract. So this area is in close proximity, and it can lead to the origin of a ventricular tachycardia that can have a very close morphology. So talking about the morphology, the right precordial leads is an important lead to be able to figure out where this idiopathic VT is coming from, namely lead V1. So here is again a cross-section in the heart with the right ventricular outflow tract being the most anterior structure, followed by the root of the aorta, and then the aortomitral continuity and the mitral valve. If you look at V1, you will note that as you go more posterior, the positive initial forces will increase gradually. So in the anterior RVUT, you have a strict left bundle, and then in the posterior RVUT and the coronary cusps, you will start having a small initial positive deflection. And as you go posterior to the aortomitral continuity and the mitral valve, you will see that the forces will be predominantly positive. So this will give you an impression on where the VT is coming from. So let's have a quick example. So this is a left bundle branch block tachycardia with an inferiorly directed axis. So the first thing that pops in mind that perhaps this is an outflow tract tachycardia, and having a late transition and strictly negative forces in the right precordial leads with an early transition between V3 and V4 points to the RVUT as a possible option of the origin, contrary to what we see in LVOT origins. So this is in contrast with the previous example. We see here from the get-go in the right precordial leads, we have initial positive forces with an early transition that lies between V2 and V3. Again, the axis is inferiorly directed, so that it would be more consistent with an origin from the left ventricular outflow tract rather than the right ventricular outflow tract. Again, as we go more posterior, the forces in the right precordial leads is starting to be positive from the get-go without an initial negative deflection. And that would point to an origin that occurs from the mitral annulus, namely the superior mitral annulus, because again, the forces in the inferior leads are still positive. We can even try to localize the origin of the PVC or the VT within the right ventricular outflow tract. So the rule is, as you go more septal, you involve more His-Purkinje fibers, and you have a narrower QRS complex that is less notched. While if you go more towards the free wall, you will have a wider QRS complex with an increased probability of notching of the QRS complex. We can do the same when it comes to the left ventricular outflow tract. So we can localize whether these PVCs are coming from the right coronary cusp or the left coronary cusp. There are some clues. So tachycardias coming from the left coronary cusp usually have a W pattern in lead V1, and the QRS complex is usually negative in lead 1, while tachycardias coming from the right coronary cusp usually have a small R in V1 and a broad R wave in lead V2. As we mentioned before, the non-coronary cusp usually does not result in the originating ventricular tachycardias. It could be implicated in some forms of atrial tachycardias, or perhaps the insertion of some pathways. Again, there are particular pattern to each site. So you can find here a template for a VT that was originating from the commissure between the right and the left cusp. And this is another one that was originating from the junction between the AIV and the great cardiac vein. This is obviously a very small area. You can have these patterns, but there is certainly overlap. And the best thing to do here when you suspect this place is to be able to map all these areas and try to find the earliest spot to be able to fix it. What about the epicardial idiopathic VTs? So the most common sites is the junction between the AIV and the great cardiac vein. So that would create a morphology that is very similar to that originating from the outflow tracts. And the exact opposite spot on the inferior surface of the heart would be the crux of the heart. And that would obviously create an axis that is superiorly directed. So how would you know whether this is a tachycardia originating from the epicardium? There are some clues. One of them is the precordial MDI. So the precordial MDI, or the maximum deflection index in the precordium, is basically the division of the interval that starts with the QRS complex and ends in the peak of the R wave in the precordial leads, divided by the whole QRS duration. And that would, of course, tell you whether the initial part of the QRS complex is delayed or not. If it's delayed, that means that probably you're engaging the His-Purkinje system delayed in the QRS activation, pointing to a possible epicardiac origin. And the cutoff that was proposed in this study was an MDI of 0.55, above which this is a possible epicardial origin, below which probably this is an endocardial origin. Of course, each sign would have its limitations. So in terms of management, the presence of a sustained ventricular tachycardia per se is an indication for management of these patients. This is, of course, accentuated by the presence of highly symptomatic attacks, the association with syncope, or the presence of frequent attacks. So how would you manage these patients? There are two main lines of therapy. The first line is medical therapy, whether it's a beta blocker or a calcium channel blocker, sotalol, a class 1C antiarrhythmic, or amiodarone. It's important to realize that the decision to pick one antiarrhythmic over the other is not based on where the tachycardia is coming from. It's rather based on the patient profile and the comorbidities. So perhaps with the same PVCs and same burden, you would refrain from using sotalol in an older female who has an impaired kidney function, and in another patient with structural heart disease, you probably would refrain from using a class 1C antiarrhythmic, and you might find yourself obliged to use amiodarone in patients with severely impaired myocardial function, where the PVCs could be implicated in the generation of the LV dysfunction. So what about catheter ablation? Catheter ablation is indicated for patients who are refractory to medical treatment, or if this is the patient preference from the get-go, if this patient does not want to live his life on medical treatment. So what we do in the cath lab, this is kind of a basic stuff. I'm not going to go into the details for the sake of time. We basically try to find where the tachycardia is coming from, and the most commonly used techniques is an activation mapping technique. So you try to find the earlymost spot in the chamber of interest during the PVC. So for this, for example here, these are patients, these two beats are sinus rhythm beats. The third beat here is a PVC. You try with your roving catheter to find the early spot. Here we can see a very early potential that was late in sinus rhythm. Now it's almost like 100 milliseconds ahead of the QRS complex or so. And if you ablate this early spot, you probably will fix this PVC. So the concept is, as you go closer to the site of origin of the PVC, you probably will get the earliest spot. And if you use a unipolar recording, all your signals will be going away from the spot of origin, which will make a deep unipolar signal, namely a QS signal. So for this, for example, here, if you're at point C, you have a late bipolar signal and a not so sharp unipolar signal. As you go closer to the site of origin at point P, point B, you will find an early electrogram, but the unipolar signal starts with an initial positive deflection. And when you get at the spot of interest, which is point A, you will find a way early signal and a negative QS complex that points to the origin of the tachycardia. Another way of doing this, when you don't have an enough burden of PVC, is what we call pace mapping. So the idea behind pace mapping is that you know where the PVC is coming from, what morphology it makes, and you try to pace in different sites of the heart, of course in the chamber of interest, to see whether you can imitate a 12/12 match of the morphology of the PVC. So for example, when you pace at a distant site here, you have a match that is poor to the match of the clinical tachycardia, but when you pace at the site of origin of the tachycardia, you get a 12/12 or a good pace map. You know that probably this is a site of origin. Of course, this maneuver has its own limitation, but again, it's a modality that we are sometimes forced to use when we're dealing with a low burden of PVCs. So to wrap up, and these are my take-home messages, 12-lead electrocardiogram remains to be one of the most valuable tools for localizing the site of origin of idiopathic VT. Medical treatment and catheter ablations are the mainstay of therapy. ICD is almost never utilized because these patients are usually not at high risk of sudden cardiac death, and they have basically by definition normal heart. Activation and pace mapping are the mainstay of intracardiac idiopathic VT ablation localization and ablation. And with that, I conclude. Thank you so much.
Good.
Thank you, Ahmed. A fantastic talk, excellent timekeeping, and I see that you excel still in your teaching abilities and your prowess of ECG. So I think we will move to the next talk, and we can take the questions at the end of that. So with this, we are coming to the last talk, and a great one. I am honored to introduce Professor John Sapp. Professor Sapp is a clinical cardiac electrophysiologist at the QE2 Health Sciences Center in Halifax, Nova Scotia. Since 2002, he's professor of medicine and is also cross-appointed to the Department of Physiology and Biophysics at Dalhousie University, where he also serves as Assistant Dean of Clinical Research for the Faculty of Medicine. He is past president of the Canadian Heart Rhythm Society and co-director of the Dalhousie University Cardiovascular Research Group. His clinical and research interests include methods for reducing sudden death, improving cardiac mapping, catheter ablation, and clinical management of ventricular arrhythmias. Additionally, I would like to say that AKU Heart Rhythm owes a lot to John Sapp, the Halifax group, including Professor Martin Gardner, Dr. Rathika Prakash, the late Dr. Magdi Basta. So welcome, John. The floor is yours.
Thank you very much, Amar. It is a great pleasure to join you today and to see some friendly faces Amr and Ahmed are some of our best fellows to train with us. I'm talking to you today. It's morning here. I realize I'm the last speaker, keeping everybody from supper there. So I'll try to stay right on time. These are my disclosures. I am on the other side of the ocean, just for those of you who don't know where Halifax is. We're right here. Can you see my pointer on your screen?
Yes, we can.
Okay, yeah, we're right here on the east coast of Canada. As I mentioned earlier, a little bit remote from most of Canada. If you'll forgive me, my slides have become a little bit disjointed. I'm just going to see if I can get them to back on track here. Okay, here we go. I've been asked to talk about scar-related ventricular tachycardia, and I wanted to approach these four main topics. First, sudden death has changed. It has now become a chronic disease with the implementation of modern medical therapy and implantable defibrillators. So where formerly patients simply died, now they are living and they need to be managed and treated. We do have treatments that are aimed at managing their prognosis, and others that are more directed at managing their symptoms. And then I wanted to talk a little bit about where I see the frontiers of management for VT. I kind of like to think about a patient's clinical course from beginning to end, and this gives us an idea of where we have opportunities to intervene on their course, make their lives better, and hopefully make them longer. So it usually starts with some kind of cardiac injury early on, whether that's a heart attack, myocarditis, non-ischemic cardiomyopathy injury, however that starts. Then some kind of magic happens. We don't know what happens in this period of time, but let's say this is a heart attack. They don't usually develop VT for another 5, 10, 15, even 20, 25 years. It's years to go by, and some kind of remodeling is occurring during that period. That means they now have the substrate for VT. Once they present with ventricular tachycardia, usually an implantable defibrillator will be indicated. But then they may go on to have recurrent VT. Sometimes VT recurs. Sometimes we get into a VT storm and repeated shocks, as Dr. Kadir talked to us about. And ultimately, the ventricle may fail. So these are our opportunities for intervention where we can try to prolong that course, make it better. And that might be with a defibrillator, ablation, drugs. And that's where we're going to focus our talks today. Heart failure and ventricular arrhythmias go hand in hand. This is a composite of a bunch of cardiac trials where we've looked at the causes of death. And if you look, sudden cardiac death makes up approximately half of the deaths in this middle group of functional class 2 to 3 patients. So it's a huge burden on our patients. What's the best way to prevent VT? Well, that would be to prevent whatever the myocardial injury was, of course. So risk factor modification, early revascularization. Do we have a way to prevent that ventricular remodeling that leads to VT? That's a different question. We think so. And that will be with optimal post-MI medical therapy and optimal pharmacotherapy for heart failure. But I'd like to propose to you that once a patient gets VT, they kind of have it as a disease, as a diagnosis, and they are prone to having it come back. The large majority of patients who have one episode of scar-related VT have another episode. And once that remodeling has occurred, once the functional and anatomic substrate have converged to make it possible to have VT, it's likely that the conditions that precipitated it will occur again. What are those conditions? Usually it is some confluence of ventricular scar. So in this case, it's a heart attack scar, but of course, any kind of scar where the scar patches together and you leave inside it some viable, often non-contractile, but conductive tissue inside the scar that can facilitate re-entry. And as it goes around that loop, it re-enters and causes VT. Once the patient has VT, their prognosis changes. And VT is an adverse event in a patient's evolution. So just as a thought experiment, I put together a couple of clinical trials. These are old trials, so take that for what it's worth. But this is the MADE-IT2 trial and the AVID trial. MADE-IT2 was a primary prophylaxis trial of ICDs, and AVID was a secondary prophylaxis trial. The MADE-IT2 trial is, these patients are more of a heart failure group, and the AVID group are more of a VT presentation. So let's just look at the functional class of these patients. In the MADE-IT2 group, 3/4 of them were sorry, I actually want to show you down here. 1/4 were functional class 3. And sorry, I'm not saying this right. In MADE-IT2, let's say 3/4 were functional class 1 or 2, whereas in AVID, the VT trial, only half were functional class 2. The ejection fraction in AVID was higher at 30%, where it was only 23% in MADE-IT. So by all accounts, the MADE-IT patients should be sicker. They should have a higher mortality. But when I superimpose their mortality curves, look what happens. Here's the secondary prophylaxis group, and superimposed the primary prophylaxis group. So at 2 years, they match up with one another. So VT has turned patients with a higher ejection fraction and higher functional class into patients with a lower functional class and lower EF. I mean, matches their mortality risk. What changes mortality once a patient has VT? Optimal medical therapy does. Beta blockers, ACE inhibitors, the usual pharmacotherapy. But defibrillators make the big difference for VT. And so this has been shown in multiple trials. I don't think I really need to reiterate that for this group. But I do want to show you this, which you may not have seen before. Some of you might remember the RAFT trial. That was a randomized trial of biventricular defibrillators versus regular defibrillators for patients with an EF under 30 and a wide left bundle branch block. There were 1,800 patients in the trial, and we had access to the defibrillator downloads from those patients. So we took all 15,000 arrhythmias and evaluated them in those patients to try to see what's the impact of cardiac resynchronization, biventricular pacing, on ventricular arrhythmias. Here's what we saw. In the patients who'd never had an arrhythmia, we saw that biventricular pacing slightly reduced the new onset of VT. In the secondary prophylaxis patients, that's patients who already had the substrate for VT, cardiac resynchronization had no clear effect, but if anything, a slight trend to making it a little tiny bit worse. So perhaps this isn't evidence of us being able to prevent that remodeling, that magic part where the patient develops the substrate, the functional and anatomic substrate for VT. One of our students took a look at multiple trials of cardiac resynchronization and saw this small signal from virtually every trial that if the EF improves with cardiac resynchronization, they also get less ventricular arrhythmias, delays onset of ventricular arrhythmias. So I think this is true. I think that we do have an opportunity to prevent some of that remodeling and act early. Cardiac resynchronization being one of those opportunities, but also pharmacotherapy. I'll move ahead. Okay, but what about when we're a little farther along that patient's clinical course and the patient has developed VT? Now what? So now we're talking about patients down on this part of the spectrum. How do you manage VT? Well, their defibrillator needs to be programmed properly. It needs to be programmed to try to not treat short episodes of VT. What we saw in the early ICD trials was that we were giving 3 times as many shocks as we were saving lives. In other words, the defibrillators were treating 3 times as many people as we saw mortality reduction in comparison to medical therapy. And that's because we were treating what was destined to be a non-lethal or non-sustained arrhythmia at some of those times. The more recent trials on how to program a defibrillator have shown that it's safe and even better to program a prolonged detection interval, give the heart a few more seconds to revert back to sinus rhythm on its own. The other things that we can do for managing VT are drug therapy, antiarrhythmic drug therapy, and catheter ablation. So on to another theme. This is a look at our own data that showed that patients who have defibrillator shocks have a worse prognosis. That's not to say that the shocks are necessarily causing the worst prognosis, just that it goes hand in hand with worsening ventricular function. This is another sub-study we took from the RAFT trial. We looked at clustering of ventricular arrhythmias. So Dr. Qadir talked to us before about treating ventricular arrhythmia storm. We've known for many years that when ventricular arrhythmias start to cluster, it seems like things go worse. And that's been shown in multiple trials. When we looked at the RAFT trial, we saw that yes, clustering of arrhythmias is associated with a much less friendly survival curve. We wanted to know, well, how much clustering? Is it 3 in 24 hours as we have traditionally defined it? Ihab Al-Sakari, one of our former fellows, completed this analysis for us. We tried modeling every which way you could try to define VT storm. And guess what? There is no clear cutoff that however many in one day is when your mortality risk starts to climb. It is the simple message that the more you have, the more you get. You know, the rich get richer. And the more VT storm, the more VT you have, the worse things are. And it starts with as small a cluster as 2 episodes in 90 days, you see that the mortality curve starts to go up. Do the shocks themselves play a role in increasing mortality? I think the answer is maybe a little bit. So increasing ventricular arrhythmias are probably a marker of things going worse, of the ventricle getting worse. But our treatments for VT are probably also slightly harmful. It is the risk that we take for reducing the shocks that the patients experience. And the best evidence for this that we can find is from these trials where we program the defibrillator to avoid shocking and just treat with ATP or delay making the diagnosis. And each of those trials has showed a small but reproducible signal to a lower mortality rate. So I think even our therapies are costing the patient something. Okay, what if we move on to trying to suppress VT? How do we suppress VT? Well, we have 2 main therapies, drugs and ablation. The best drug that we have is clearly amiodarone. And forgive this old slide, probably most of the audience is too young to remember the CAST trial. I was in medical school when it was published. But it killed a bunch of antiarrhythmic drugs that were invented in the hopes of preventing ventricular arrhythmias. All those class 1 drugs where we really thought that we would be able to intervene on the cellular basis and change the risk of death. And those drugs do reduce non-sustained VT and PVCs. Sadly, they increase the risk of death. Multiple antiarrhythmic drugs have made it to market or almost to market and then been killed because of this same risk. They all do take a risk and have sort of failed to make it to mainstream therapy. So we're left with very few antiarrhythmic drugs. The two with best evidence for treating scar-related VT are amiodarone and sotalol. Two major trials that include sotalol and one with amiodarone in the ICD era. There are, of course, many other trials that include amiodarone that don't take into account the effect of ICDs. But here's the short version. Sotalol reduces the risk of ventricular arrhythmias by, at 1 year by about 40%, amio by about 70%, 75%. Sotalol comes with it. There's another bad pun on a clinical trial name. The SWORD trial showed an increase in mortality from D-sotalol in patients who did not have defibrillators. And I'm showing you this curve on the right from the SCUD-HEF trial. So this is not often talked about, but the SCUD-HEF trial was stratified by functional class. And in the functional class 3 patients, amiodarone was actually associated with an increased risk of mortality. Okay, there was no effect in the overall trial and no adverse effect overall on mortality in functional class 2 patients. But I think there is a signal that amiodarone makes heart failure worse or increases mortality risk. It might be by causing left bundle branch block and dysynchrony. It might be from organ toxicity. I don't know. Okay, what about catheter ablation? I showed this before. Here's how catheter ablation is performed. So let's say that this is our reentrant loop in this patient's scar. The goal is to direct your catheter to the region of the scar where those channels exist, hopefully just to areas which don't contribute to myocardial contractility, and create an ablation lesion, knocking out the channel and hopefully not affecting ventricular function overly. So what about clinical trial evidence for this? When I started 20 years ago, there was zero. Now we do have some trials, fortunately, to help us guide therapy. There have been, surprisingly, several trials set here early on in the VT course. So, but these are kind of proof of principle trials that catheter ablation is effective in treating VT, but they weren't comparisons against antiarrhythmic drug therapy. The results of these trials, like SMASH VT, showed again a reduction in recurrent VT with ablation. Same with the VTAC trial, obviously a higher risk population or perhaps better longer follow-up. This trial from the VTAC group showed no difference, but those were in patients who did not have hemodynamically tolerated VT. Again, these are relatively earlier trials. And the VANISH trial we published in 2016, which showed that catheter ablation is superior to escalating antiarrhythmic drug therapy. So the VANISH trial asked the question, what should you do when first-line therapy for VT fails? So when drugs fail. This is how we designed the trial. When sotalol fails, patients were randomized to either ablation or initiation of amiodarone. And in a separate stratum, if amiodarone failed, they were randomized to either escalation of drug therapy with higher dose or addition of mexiletine versus ablation. These are the results for the overall trial. A 28% risk reduction for recurrent VT or mortality or shock or storm. And it breaks down like this. No clear impact on mortality from ablation. The primary outcome was driven by a reduction in storm and reduction in appropriate ICD shocks. When you break it down by the sotalol refractory patients versus amio refractory patients, most of the benefit showed up in the patients who were refractory to amiodarone. So you might say, well, no kidding, dummy, you know, they already failed amiodarone. Why are you giving them more amiodarone? It was common practice at the time. So, but a big reduction in recurrent VT or mortality in patients who had VT despite amiodarone. We've done a number of sub-studies to try to further understand what we were seeing. I'll just whiz through those if it's okay. Again, no real impact on mortality in either of the groups, but a substantial reduction in recurrent VT in amio refractory patients. In sotalol refractory patients, amiodarone, de novo amiodarone, and ablation were fairly similar. So this has important implications, especially if you are making medical decisions that hinge a lot on cost to the patient. So you know, it is quite reasonable to implement amiodarone at least over a 3-year time follow-up horizon for patients who failed sotalol. We looked at cost effectiveness, and we saw something rare and wonderful. First of all, in the overall group, the cost per life year saved is about $25,000. So in a Western context, that's generally considered reasonable. But in the amiodarone refractory patients, so VT that occurs despite amiodarone, and you're deciding, am I going to ablate them or give them higher dose amio or add mexiletine? Not only were the outcomes better with ablation, it was cheaper. Lesser costs on hospitalizations, lesser costs on repeated procedures, and so on. We looked at the group who received mexiletine. And mexiletine is, well, let's just say it is not very effective. Adding mexiletine does very little to prevent VT. Ablation was far, far more effective. In terms of quality of life, ablation had improvements in multiple aspects that we were able to measure on quality of life. I won't go through them all in detail. We also found that if you do an ablation, if you're able to achieve non-inducibility at the end, the patient is more likely to have a better outcome, less likely to have recurrent VT. No surprise there. We also noticed that, as many of you know, opening up a coronary artery in somebody who's got VT, opening an artery into their scarred ventricle makes very little difference. So VT alone is not an indication for revascularization. Okay, we're in the home stretch here. We're now running the VANISH2 trial, which asks the question, what should first-line therapy be for ventricular tachycardia other than a defibrillator? So should we be going straight to amiodarone or sotalol, or should we be going straight to ablation? This is the design of the trial. We're taking patients who've had a prior heart attack, come in with VT. They must have a defibrillator to be in the trial. And they're randomized either to drug therapy or catheter ablation. If they're randomized to drug therapy, it's in one of these two strata. Again, the trial is stratified into two separate arms, those who are amiodarone eligible and those who are sotalol eligible. We're using standard drug dosing proven to work in clinical trials. Maybe I'll move ahead on some of the details. The endpoint is going to be a similar composite to what we had before: death, appropriate shock, VT storm, or sustained VT below the detection of the defibrillator. We have a target enrollment of 374 patients, and so we expect to finish enrollment later this year. We'll need to follow the patients for another couple of years before we have final outcomes. I can tell you, I have no idea I know how enrollment's going, but I have no idea how the different treatments are stacking up. I'm blinded to all of that until we lock the database, and I'll finally be allowed to see it. But they're mostly class 2 patients, some functional class 1 patients. They're fairly standard patients with VT. They're hypertensive, diabetic, hypercholesterolemic men. And they have a fairly high burden of VT that's got them into the trial. A mean of 2 shocks and as many as 12, a mean of 12 VT events treated by their device. And they're well treated pharmacologically. So more to come on that once we have the results of that trial. I just want to finish with this slide, trying to look at what are the questions that need to be answered now. Where are the frontiers of our knowledge for treating VT? I think we've got a lot to learn about how that injured heart, how that scar morphology becomes a VT circuit. Can we predict that better? Can we treat it prophylactically if we can predict it? Are there non-invasive ways to treat it? What's the right time to intervene and suppress VT? I didn't mention the Berlin VT trial published last year, which showed no real benefit of ablating VT very early as opposed to waiting until VT recurred a couple of times. What's the best way to suppress VT? We're still working on that, as I showed you. And we really don't know that suppressing VT improves mortality. All of our trials or studies that have suggested a mortality benefit are retrospective and very subject to that healthy survivor bias, showing that people who don't get more VT are more likely to survive. Well, that's because they're healthier. So we really need to look at that in a prospective fashion if we want to try to understand the impact on mortality. And finally, most of what I've said applies mostly to ischemic cardiomyopathy. We have a lot less data in non-ischemic cardiomyopathy where the scar is more likely to be mid-myocardial or epicardial. Catheter ablation is less effective and requires a more aggressive approach. So maybe I'll stop there, and I'm not sure if I'm conscious that it's dinner time there, and happy to take any questions if there's any time left. Thank you very much.
John, thank you. Amazing talk. And I think in our perspective, we see a lot of coronary artery disease over here, and we see people very late with the poor LV functions, and we do not have as robust a general practice system in the country like Canada has or the US has, where people are taken care of. So I think this is very relevant, what you've said. And I see that in the past decade that I was at Halifax, things have changed in the sense that we are now delaying ventricular tachycardia ablation and going with some medical therapy as well. So a lot of knowledge has come through. Any thoughts as to how should, because our patients are not very well medically treated over here, and they come in with the well-defined scars by the time they reach medical help. So they don't reach in time. Would there be any difference in our approach?
I mean, approach in terms of how to treat the VT, or how to...
No, in terms of overall managing the patient. Now you see there are newer drugs coming in, and heart failure mortality, despite the fact that all the drugs that have given mortality benefit, there is still room for improvement. So we use a lot of amiodarone over here because we do not have setups where we are doing ischemic VTs. So your thoughts on a system where, I know it's a very tough question. We are always talking about it.
Yeah. I've come to the conclusion that patients, once they get VT, they kind of have it. And like I said, I don't really understand how that remodeling works. Why does it take 20 years for them to develop VT after a heart attack? We don't know that. The thing about amiodarone is it works. It does work. It is effective in reducing VT, and I will not be surprised if it is as effective or more effective than first-line catheter ablation. Catheter ablation is more effective than escalating your amiodarone when it's not working. But I think if you're talking about first-line, but with the evidence that we have now, I think amiodarone and catheter ablation for recurrent VT are both, they're reasonable interventions. The price you pay with ablation is cost, financial cost, and upfront risk to the patient of procedural complications and risk. The cost that you pay with amiodarone is long-term side effects and long-term organ toxicity. So what we saw in the Vanish trial was quite a bit more adverse effects, side effects in the amiodarone group. 2 pretty bad lung injuries, and a number of other adverse effects in the amiodarone group. So more toxicity for sure. And that's just a trade-off that one has to make. And if we had better drugs, that would be wonderful. If we had less risky ablation, that too would be wonderful. Maybe as we all get better at it, the risk will continue to come down.
Well, thank you very much, John. Excellent talk. And I would now request General Imran Majid, who's chairing the session, to give his final comments before I would invite.
Amir, I have a question with
sure.
Dr. Sapp.
Sure, go ahead.
Dr. Sapp, any for patients who have primary prevention patients with ischemic heart disease, any ways to further risk stratify, like microvolt, T-wave alternance, the signal average ECG, because we have again the resources are limited, and we really want to know which patients are going to have VT in those primary patients. Any thoughts about that? Further, further trying to find out the high risk category further, because the cost is an issue for ICDs and all that thing.
Yeah, no, this is a great question. If we have time to answer it, so further risk stratification it does work. So T-wave alternance does predict a higher risk. Fragmented QRS predicts a higher risk. There are ways to predict who's at even higher risk. Most of the research now is actually not aimed at what you're getting at. You know, we put in a primary prophylactic defibrillator and 80% of the patients never use it. And the cost benefit calculation's been made that that's okay, you know, if society can afford that. If you can't afford that, what's the cutoff, and how do you identify within your high risk EF group? So the ejection fraction is a terrible test for predicting risk. It works, but it has 25% sensitivity and 25% specificity. We wouldn't accept that kind of sensitivity specificity in many tests, would we? But we accept it for this because we don't have much better. We're right now doing the REFINE ICD trial. It's headed by Derek Exner in Calgary, and taking patients with an EF over 30% or over 35% rather, and under 50, and using T-wave alternans to identify within that subgroup a higher risk group and randomizing them to defibrillator or not. So we're not answering the question you're asking. We're looking for the high risk group in those who are not getting defibrillators, using current guidelines. And you're asking a very good question of how could we identify among those who have a current, AHA class 1 indication, how can we identify those that really need it? Very little research on that happening right now, but it may be that things like T-wave alternans could do it. Nothing has been clinically validated though. So very, very long-winded way for me to say I don't know.
Yeah. Thank you. Anyone else on the panel? EP always has questions, and we love discussions, and we don't worry.
Amir, I have a question for.
You can ask the question, John, and then wrap up. You'll give your final comments as chair of the session.
Yeah. Amir, I need to ask John that when we are dealing with a monomorphic ventricular tachycardia, if the shocked events by the device are monomorphic ventricular tachycardias, then probably we do not need to worry about revascularization. But I'm very uncomfortable when I'm dealing with the situation that the shocked events are polymorphic ventricular tachycardia or ventricular fibrillation. There, I am not very sure. So John, what are your comments on that?
I agree with you 100%. Polymorphic VT and VF are a cry for help from the myocardium. That is the heart saying, help me, something's wrong. It's like geriatrics. When a geriatric patient has delirium, it's non-specific. It's a non-specific response to any of 10 different things. Who knows whether they have a UTI? It's the same, I think, with the heart. When you see VF and polymorphic VT, something is wrong, and it's your job to figure it out what it is. Sometimes you can't find anything, but many times it's ischemia, electrolyte, heart failure, or something else. So I 100% agree with you.
Yeah, thank you. So Amir, if I may, it's my privilege and responsibility to thank you. Firstly, Dr. Amir Hamid and all his team, and the Aga Khan University management for putting up this conference, which was, I believe, a 4-day conference. The fact that EP did get attention, at least for one session, is I suppose thanks to Amir's endeavors. And this is because EP is still a relatively new entity in Pakistan. Basically, as everybody alluded to, the issues related to EP have been cost issues, whether it's ablation or devices that we talk about. But nevertheless, many thanks to the speakers. We had good sessions that starting with lead extraction, atrial fibrillation, ablation. Again, we discussed cost issues, particularly in context of situation of clinical practice in Pakistan. And again, the same issue comes up when we talk about use of mapping systems. Arshad Jahangir did a commendable job. I think, we being very unfair on him, trying to make him have us go through all aspects of genetics related to arrhythmias in this confined time period. I was just wondering, a great attempt at trying to bury haystack in a needle, and he almost got there. And then great talks on electrical storm by Faisal Qadir and Dr. Eldamaty talking with clarity about idiopathic ventricular tachycardias and their ablation. And again, John Sapp, thank you for sharing your thoughts again about this challenging field of scar-related ventricular tachycardia. And again, appreciative of your clarity, although again, you did a great job trying to bury haystack in a needle. The good thing about these conferences is that now that we have this convenience of having these online so frequently, which is not only convenient, very convenient, but also cost effective. And I hope that we can have more of such sessions in the near future. It's heartening to see that Aga Khan University has also endeavored finally to put up something on cardiac electrophysiology. So Amir, we'll be expecting more of such endeavors from your side. And gentlemen, thank you very much.
Thank you, General Imran, and thank you, everyone. Now I would request the co-convener, Dr. Osman Fahim, to come and give us the closing, because this is the closing session for the conference. So Osman, over to you.
Assalamu alaikum, everyone. Sorry, my camera seems to not be working, but I've been listening avidly to the EP session, and in response to General Saab, yes, Amir and Yaver both, over the years, Amir has endeavored to establish EP at AKU very successfully, and then brought over Yaver. And as a team, they're doing fantastic work. And EP, I think, as a general cardiologist, interventional cardiologist, is something that we strive to learn, but at times it's when you need an EP person, you really need an EP person because nobody else can fill that role. So it's heartening to see that the focus that's being given, the talks themselves were at an unbelievable academic standard, and the discussion and question and answer and the discourse was just amazing. I'm going to pull up some notes here, and I have to thank in closing. So, we had this conference over 4 days, and all subspecialties: imaging, interventional cardiology, adult congenital heart disease, electrophysiology, got one session each. And this is the end of our 4-day conference today. I'd like to thank the chair of the session today, the panelists, the incredible speakers who took time out from their busy schedules and their Sunday time with families to speak and share their knowledge with us. So I'd like to thank our Dean and CEO, our Professor, Dr. Zainab Samad, who's convener and chair, Chair of the Organizing Committee, Dr. Professor Amir Hamid, Chair, Scientific Committee, Dr. Javed Tai, Co-Chair of the Scientific Committee, which is Dr. Sarah Bukhari, and our administrative assistants, Sana Makhani, Salima Karani, Mariam Cambo, Zara Khan, and Barbara. Our IT team, Irma and Gansham, and Hania from communications. All of our cardiology faculty who've been working behind and in front of the scenes, doing workshops, attending sessions, moderating sessions, our nursing colleagues, and our cardiology residents and fellows, our chief resident, Shima Sadia, and our medical students, Ali, Maha, and Vakas. Because of all of you and because of them, this conference has been a tremendous success. And we're looking forward to continuing the discussion, continuing our academic discourse with all of you, and hope to see you again next year, inshallah, at Pulse 2022.
Thank you.
Thank you so much. Over to you, Dr. Amir.
Okay, thank you. I think Osman has closed and with a promise for next year, but I think we are going to have more EP sessions. And I think with COVID has actually given us this advantage. Otherwise, physical travel was very difficult. I wanted John to come here years ago. It has taken me 10 years to have him finally. Ahmed, and we have one other superstar at Halifax, Amir Abdul Wahab. So hopefully we will have more participation, and we promise to hold these more regularly now. Thank you, and good morning, good evening, good afternoon globally. Take care.
The opportunity to be here.
Bye-bye.
Thank you.
Bye-bye.